Hello dear students, myself Dr. Madhuri Srinivas, your dermatology faculty in this wonderful Cerebellum Academy. So in this video, we are going to see the quick revision of the dermatology subject. And what are the topics which we are going to discuss in this particular video? We are going to cover the basics of dermatology, very, very important to understand and also remember. Many questions have been asked on this: hair, nails, head, necks and appendages and blistering disorders, that is vesiculobullous disorders. So what is new in this version 2.0? They are going to be more stories, not just information, and more memorable experience is going to be there for all of you students. And yes, there will not be any boring content. Yes, interesting information is going to be shared, and not just dry information but just more and more images, and there are going to be so many stories. As I've already told you, there will be so many movies and integrated into the topics of dermatology, with the help of which you can easily remember what are the points related to that particular disease. And this is not going to be just some course completion type of a video. We are going to also see how to memorize whatever we are going to listen in these videos, and latest PYQs are going to be discussed and incorporated into the theory class itself. And one more suggestion for all of you: remember to revise whatever you have read ASAP, as soon as possible. If you revise this, you are going to remember the topics for a longer duration. That is what you need to remember. Yes, these were the highlights, and yes, we are going to start. We'll set your screens on fire with dermatology subject. So coming to the basics, very, very basics. What are the layers of the skin? What is the function of the skin basically? So the main function is going to cover all the organs, thereby it is going to provide protection to the body. And so you should know the basics, very, very basics of the skin. Then only you can understand what are the diseases which we are going to discuss in the upcoming sessions. Okay, so first of all, you should know layers of the skin broadly can be divided into dermis. Above the dermis we have epidermis, and below the dermis we have hypodermis. So you should also know what are the sub layers of the epidermis. So in the epidermis, please remember there are again 5 more strata. So what are those strata? You can remember these with the help of this simple mnemonic, or we can say a trick. It is Sunburn Festival. I hope you might be knowing this. This is a music fest which happens every year in the Goa in the last week of the December month. Come, let's get sunburned. That is the mnemonic for the layers of the epidermis. So what is C? C stands for stratum corneum. I will just highlight here. It's corneum. L for lucidum. G for granulosum, S for spinosum, and B for stratum basal. So come, let's get sunburned. This is how you can easily remember the layers of the epidermis. And I wish you all of you are going to get great success, and you are going to call me for the grand party in the Goa. Come, let's get sunburned. But before that, yes, you need to work very hard. You need to burn like a. So coming to the points related to each of these layers of the epidermis, remember the stratum basal layer, which is the deeper layer of the epidermis. It is the first layer which is going to be present. From this layer, the rest of the other layers of the epidermis will be produced. So that is the reason why this is also called as stratum germinatum, and this is the active layer in the epidermis where mitotic activity is going to take place. And you can remember that it is a single celled layer which is going to have a central nucleus. So the next layer which is produced from stratum basal is called as stratum spinosum. And why is it called as spinosum? Because it is this layer in which there will be maximum keratin synthesis happening, and also you should remember there are desmosomes present in this layer, desmosomes present in maximum concentration in this layer. The desmosomes are basically spinous projections which help in interconnecting the adjacent keratinocytes with one another, and on microscopy they were appearing like spines. So that is the reason why this layer is called as stratum spinosum. So the next layer which is produced is called as stratum granulosum. Why is it called as granulosum? Because there are granules present in this layer. What are those two granules which you should remember. One is keratohyalin granules and the other one is odd-land bodies or lamellar bodies. So what is the function of the keratohyalin granules? Please remember, it is going to produce what is called as filaggrin. So initially there will be profilaggrin which will be converted into filaggrin. Filaggrin is basically filament aggregating protein. Filament aggregating protein. So it is this filaggrin which will be defective in two important diseases which you should remember. One is atopic dermatitis and the another one is ichthyosis vulgaris. Okay, we will see once more again these two things when we discuss about the respective topics. And next we have stratum lucidum. What is the significance of the stratum lucidum? Is it is present only in the palms and soles. That is the classical point about the stratum lucidum. And you need to remember there are granules, yes, called as elidin granules produced by this by the cells in this layer. Okay, remember that is the reason why palms and soles are basically comparatively less hyperpigmented. So they are, we can say, very bright white in color when compared to the rest of the skin. Next we have the stratum corneum, which is basically composed of dead cells. So yes, there will not be any living cells here. All the cells are dead. This is a dead layer. There will not be any nucleus in this layer, and there are flat cells present in this layer. Okay, so this is a picture which is showing you all the layers. So you can see this is a stratum basale, spinosum, granulosum and corneum. Usually for all practical purposes, stratum lucidum is not going to be depicted in these images. Why? Because it is only present in the palms and the soles. And there is one more concept I have told you, that from the stratum basal the cells are going to move upwards, isn't it? So remember the time taken by the stratum basal cells to reach the stratum corneum and to ultimately get shed off into the environment. This time period, it is called as epidermal transit time, skin doubling time or skin turnover time, and you can remember it is approximately 8 weeks. But if anyone asks you for a range, you can remember it is 42 to 75 days. Okay, so this is the epidermal transit time. What is the clinical significance of this? There is one disease which is called as psoriasis, in which this transit time is going to reduce to 1/10. So what will it be now? It will be 4 to 7 days in psoriasis. That is the reason why clinically we can see silvery white scales in the patients of psoriasis. So next, I have told you in the stratum spinosum. Why is it called spinosum? Because there were spinous desmosomes in that layer. So this I am giving you the perspective. So this is the stratum corneum, this is stratum granulosum with so many granules inside it, this is stratum spinosum, and this is stratum basale. So are you able to see that these are all the epidermal cells? What are the important epidermal cells? They are keratinocytes. Yes, all these are keratinocytes. All of these are keratinocytes. And are you able to see that these keratinocytes, they are connected with one another with the help of these green projections, green spinous projections. These are called as desmosomes. You can define them as intraepidermal intercellular keratinocyte bridges. And what is the clinical significance of this? So there is one disease which is called as pemphigus. So in which there will be antibodies against the desmosomal proteins. Okay, and one more point you need to remember, the stratum basal is attached to the underlying dermoepidermal junction. Dermoepidermal junction will be there here. So this attachment is not with the help of desmosomes, but it is with the help of very important hemidesmosomes. Hemidesmosomes are different proteins. You will understand the importance of this while we are discussing the vesiculobular disorders topic. So this is a picture, microscopic picture, where you are able to see these are the keratinocytes. These are the individual keratinocytes, and you are able to see that in between these keratinocytes we are having the desmosomes, which are very, very tiny projections, which will be appearing as spinous projections. And you need to know one more point, that is stratum malpighium. What is this? This is the combination of the stratum basale and the stratum spinosum. So both these put together, we call it as stratum Malpighian layer. So what are the cells of the epidermis? One cell you already know, it is keratinocyte, and remember keratinocytes, they are going to form approximately 85 to 90% of the cell population of the epidermis. Remember, this is very important point. And what is this movie? I hope you already identified this. This is Kalki movie. You are able to see the inverted pyramid, isn't it? So why am I telling you this? So in the inverted pyramid, who was sitting on the top, yes, this is K for Kamal Hassan. So why am I telling you this? Because keratinocytes, they are going to form the approximately 90% of the portion of the entire epidermis. So I hope all of you know this concept. We categorize depending upon the percentage in the form of pyramid. We will describe, isn't it? So remember, keratinocytes are going to form the highest concentration of the cells in the epidermis, 85 to 90%. So the rest of the other cells, so those things also you need to remember. What are the other cells? So remember, Langerhans cells, Merkel cells, and melanocytes. So these are the other rest of the non-keratinocytic cells which you need to remember. Very important. And keratinocytes, remember one more point, that these are ectodermal in origin. Very important. And inside the keratinocytes, there will be keratin intermediate filaments. This keratin intermediate filaments, I will again describe while discussing about the epidermolysis bullosa simplex. That is the mechanobullous disorder. So remember this point also. So now coming to the individual cells and their important points. Keratinocytes, you already know, they are ectodermal and there will be KIF, keratin intermediate filaments. So what is the importance of Langerhans cells? You need to know few of the important points related to each of this cell. So the location of the Langerhans cells is very important. It is stratum spinosum. And where are Langerhans cells embryologically derived from? They are bone marrow derived. So you can also remember they are mesodermal in origin. And you also should know that there will be some granules present inside the Langerhans cells. What are those called as? Very important. They will be seen only under electron microscopy. Those granules are Birbeck granules, which will be seen on electron microscopy. And what is the importance of this? There is a named appearance. These are described as tennis racket appearance. These will appear like a tennis racket. Are you able to see? There is one end which is appearing round, and at the another end it is appearing like a rod. So put together it is appearing like a tennis racket. So it is described as tennis racket appearance. And what is the function of this? This is APC. Langerhans cells are antigen presenting cells. So these Langerhans cells, basically they will have some dendritic projections, dendritic process. Are you able to see? This is the Langerhans cell which is having dendritic process. What is the function of this? Antigen presentation. So it will take up the antigens from the nearby environment, from the cells, and it is going to present it to the nearby lymph node. Okay, and what is the layer in which it is present? Stratum spinosum. Very important. It is present in stratum spinosum. And about the next type of cells, melanocytes and Merkel cells. So both of them are going to start with the letter M. So what is the significance of this slide which I am showing you? Munni Badnaam Hui. I hope you all might have heard this song. Munni Badnaam Hui. And the next song, Baby Ko Bes Pasand Hai. So we are going to remix both these songs and we are going to call it as Munni Ko Bes Pasand Hai. So why am I telling you this? Munni Ko Bes Pasand Hai, because Munni starts with the letter alphabet M, and with the help of that you can remember, yes, base. You can remember it is stratum basal. And the next two type of the cells which are starting with the M, melanocytes and Merkel cells, their location is in the stratum basal. Okay, rest of the other things are also very important. So melanocytes are derived from neural crust. Remember, this is very important. Neural crust derived, and Merkel cells are derived from ectoderm. So we'll see about the melanocytes, few important points. Melanocytes are going to have organelles which are called as melanosomes. And the function of these melanosomes is obviously production of the melanin pigment, but you should know that there is a precursor amino acid which was asked in the recent exams also. Remember, it is tyrosine. Remember, do not confuse it with tryptophan. No. Tryptophan is not the precursor for melanin. Can you remember what is the vitamin which is derived from the tryptophan, or which is produced from the tryptophan? It is very, very important, associated with pellagra. Are you able to remember now? What is that vitamin? It is vitamin B3, which is niacin. Okay, tyrosine tryptophan. Please be very careful about this. And of course, the melanoma associated, the malignancy associated with melanocytes is melanoma. And what are the important markers which you need to remember? S100, HMB45, and melanin. These are basically immunohistochemical markers to identify the melanoma, malignant melanoma. Melanoma clinical features are also important. We will see those features in the skin malignancies. Next, we have the Merkel cells. So Merkel cells, remember, they are, I hope you might have heard them in your physiology. Please remember, they are the mechanoreceptors. That is the reason why the Merkel cells, they are having neurosecretory granules present inside them. And you can remember which type of mechanoreceptors these are. These are SALT, slow adapting low threshold type of touch receptors. They will help in the perception of the touch. And there is one important malignancy associated with Merkel cells called as Merkel cell carcinoma. And what is the marker present in this malignancy to identify this? It is cytokeratin 20, CK20 positivity will be there. Please remember, CK7, cytokeratin 7 will be negative. CK7 will be negative. So this is a picture of the melanocyte which you are able to see, which is present in the stratum basale. So this is the melanocyte, which is again having this dendritic processes. Do you remember in the Langerhans cells also there were dendritic processes, but the function of the dendritic process in the melanocytes is little bit different. It is not to take something, but it is to give something. It is to give something. What it is going to give? It is going to give the melanosomes and the melanin pigment to the adjacent keratinocytes. And remember, there is one number which is called as epidermal melanin unit. So remember, one keratinocyte. So one melanocyte is going to give the melanin and melanosomes to adjacent 36 keratinocytes. This is very important number which you need to remember. One melanocyte will give the pigment to adjacent 36 keratinocytes, and this is what is called as epidermal melanin unit. So this is a slide in which I will show you what is what cell and where it is present. So if you observe, this A is this cell. What is this cell? Where is it present? Can you name it? It is not a keratinocyte, okay? It is a Langerhans cell which is having the dendritic processes. So it is Langerhans cell. Yes, and B. What is B? So this brown colored cell which is having the dendritic processes which is present in the stratum basale, it is B. What it is? It is melanocyte. Very good. If you have marked it right, melanocyte. So what is C? You are able to see it is again present in the stratum basale. And one more thing you can see, that there is a nerve which is carrying the sensations from this cell. So it is Merkel cell, which is a touch receptor, mechanoreceptor. Okay, very good. So this is yet another picture where you are able to see this is a Langerhans cell present in the spinosum, melanocyte, Merkel cell present in the stratum basale. So there is this basement membrane zone which is also called as dermoepidermal junction, which is the junction between the epidermis above and the dermis below. You need to know few important points related to this. So basically this has various subproteins. We are going to see the detailed structure in the vesiculobullous disorders topic, but here you can remember it is a specialized zone which will help in connecting the epidermis to the underlying dermis, just like a glue. So this is the actual structure. We'll see exactly what are all the components in the vesiculobullous disorders topic. Next we have this dermis. In the dermis, remember we have the papillary dermis, and reticular dermis. So basically in the dermis there is going to be important component which is the collagen, and also we are going to have the connective tissue. In the reticular dermis, Please remember the connective tissue is dense connective tissue which is irregular dense connective tissue, whereas in the case of papillary dermis, just remember it is going to form the superficial 1/10 of the dermis, whereas the reticular dermis is going to form 9/10 of the rest of the dermis. And below the dermis, we have hypodermis. Few important points to remember. Hypodermis is also called as subcutis. It is also called as paniculus. And remember, if there is inflammation of this layer, we call it as paniculitis. Okay, that is one point which you need to remember. It is broadly called as paniculitis. There are two important components which you need to remember. One is septa and the another one are lobules, fat lobules. So the septa are going to separate the fat lobules. If there is inflammation of the septa, we call it as septal paniculitis. And if there is inflammation of the fat lobules, we call it as lobular paniculitis. We will discuss these two when we are discussing the mycobacterial infections. Okay, very, very important. So here is another picture which is showing the septa. So these are the septa which are separating the fat lobules. So basically these are the adipocytes. So next, related to histopathology, there are some terms which you need to know. Okay, stratum corneum. Remember, if there is thickening of the stratum corneum, we are going to call it as hyperkeratosis. So pathological thickening of the stratum corneum is called as hyperkeratosis. And we all know that in stratum corneum, nucleus will be absent. But if nucleus is present in the stratum corneum, we are going to call it as parakeratosis. You can remember that with the help of this simple trick. P for parakeratosis, P for persistence of the nuclei. And you can see that this is the nucleus which is being depicted. In this image, in this histopath image. And in this image, you can see this is a stratum corneum. You are able to see that it is thickened. Coming to stratum spinosum, two important terms which you need to remember. If there is intracellular fluid accumulation, that is intracellular edema, we are going to call it as ballooning degeneration. And this is classically seen in herpes infections. If there is intercellular edema, that is there is fluid accumulation in between the cells. What are these cells? These are nothing but the keratinocytes. Obviously, in the epidermis, in the stratum spinosum, keratinocytes are present. So if there is intercellular edema, we are going to call it as spongiosis. And what is the important condition you need to remember? It is seen in acute form of eczema. So if there is stratum spinosum involvement, we are going to use the term acantha in the histopath. Please remember, acantha, wherever you see, it means we are discussing about stratum spinosum specifically. If there is thickening of the stratum spinosum, we call it as acanthosis. If there is a destruction of the keratinocytes, if there is damage of the keratinocyte connections, and if they are separated from each other, then we are going to use this term which is called as acantholysis, where there will be loss of attachment between the keratinocytes. And I hope all of you do remember what is that structure which is helping in connecting the keratinocytes with each other. It is desmosome. So basically there will be damage of the desmosome in the acantholysis. So remember, acantha means spine. So this picture we have already discussed. So these are the desmosomes. So whenever there is any condition where there will be damage to these desmosomes, these are the desmosomes, we are going to see that the keratinocytes will be separated from one another. And they are going to become rounded cells. So they will become round. And also they will have a central hyperchromatic nucleus. Will be there. And there will be a perinuclear halo. So these are the three changes which will occur. Perinuclear halo. So these cells are referred to as acantholytic cells, or they are also referred to as Zang cells. So what are these cells? Basically, they are nothing but the keratinocytes which have separated from one another. keratinocytes which are separated from one another, and this we are going to call it as Zhang cells because we observe these cells under the Zhang smear. By performing the Zhang smear under the microscope, we are going to see these Zhang cells. So that is the reason why they are also called as Zhang cells. Okay. And also remember, acantholysis is a process which is going to occur in the case of various conditions, but the most important one is autoimmune condition, which is vesicular bullous disorder called as pemphigus. Very important for you to know. This is very basic. Acantholysis is seen in the pemphigus. And in the infections, you can remember there are certain bacterial viral infections. In the bacteria, remember bullous impetigo and staphylococcal scarlet skin syndrome, which is also called as Ritter's disease. So in these two bacterial infections also we can see acantholysis. And in the viral infections, remember, very important, this is being asked recently in various exams, HSV and BZV, that is herpes simplex virus and varicella zoster virus. In these two conditions also we can see acantholysis. And there are certain inherited genetic conditions in which we can see acantholysis. So remember the two important names, Hailey disease and Darier's disease. Hailey and Darier's disease. Next, you need to know few points about the scales. Okay, what is the scale basically? So I am now discussing about the scales. Various types of scales are there, but you need to know what are scales. Scales are basically the stratum corneum which will be going into the environment, which will be shed off into the environment. This stratum corneum, it is called as scaling. So basically in us also stratum corneum will be shedding, isn't it? But we are not going to see that clinically. But there are certain diseases in which we can see the scaling clinically. So what are those conditions? What are the types of scales we can see? Very important. This was asked in the recent exam. So remember, silvery white scaling can be seen in the patients of psoriasis. Yellow greasy scales can be seen in the cases of seborrheic dermatitis. Browny, powdery, purpuraceous scales can be seen in the case of pityriasis versicolor. Okay, we'll see all these in the individual chapters. Do not worry about this. Yes, collarate scale, very important. Pityriasis rosea and mica-like scales can be seen in the disease called as pityriasis lichenoides chronica. So these were all the important types of scales which you need to remember. Yes, fish-like scales. Fish, wherever you see, remember ichthyosis vulgaris, and leaf-like scales. Leaf is foliage, so in pemphigus foliaceous we can see leaf-like scales. That is the description used. So next you need to remember the configuration of the various types of lesions. So first configuration which we are going to discuss is annular configuration. In the annular configuration, please remember the lesion is going to have a different periphery and a different center. Okay, so basically these are ring shaped lesions as you are able to see here, but the description which you need to remember is the activity will be present at the periphery. Okay, periphery will be active whereas center is not going to have any activity. That is, we can simply say periphery and the center both are different. So which you are able to see in this image. So this is the periphery of this favorite breakfast vada. Okay, so just like this, the lesion is also going to have a periphery which will be active, raised erythematous associated with scaling. Whereas if you see, this is a central portion. This is a central portion where you are not able to see any type of change or activity. So here again, this is a central portion of this annular lesion where you are not going to see any activity. We can say this center is clear. The center is clear. And what are the important diseases which you need to remember which have this annular configuration? Very important. So in pityriasis rosea, we have this herald patch which has this annular pattern, annular configuration. In BB leprosy, we are going to have this annular lesion. And in the tinea corporis, we have this annular configuration. Okay. And also you can see that the WADA vada has 2 A's, annular also has 2 A's. And next configuration is called as discoid, which is also described as coin-shaped lesions. So why is it called so? Because if you observe, this is the discoid lesion where there will be activity in the center as well as in the periphery. both the places we are going to have the activity, and it is appearing just like this idli, where activity is present, where activity is going to be present everywhere. So I is there, two eyes are there in discoid, and also in idli we have two eyes. So with the help of this you can remember. So the activity is going to be there in the entire lesion. Entire lesion will be active. And what are the important examples you need to remember? Discoid eczema, discoid lupus erythematosus. So in the name itself, there is this term discoid. So why is this term discoid used? Because the disc which the children, when we are young, we used to play. Okay, now also we can play. So these discs, they are having the same periphery and also the same center. That is the reason why it is called as. So there will be activity everywhere. That is, there will not be any difference between periphery and centers, just like the disc. So it is called as discoid. Whenever you see this term oid, remember it is the meaning. The meaning is like. So disc-like. So it is called as discoid. So you need to remember the various diseases which have this pattern. What are those important conditions where there are annular plaques? Annular plaque. So center, if it is having scarring, then you need to remember annular lesion which is having central scarring. The important disease which you need to remember is cutaneous tuberculosis, lupus vulgaris, and annular lesion which is having a central clearing. What is the disease? It is a dermatophytic infection which is tinea corporis. And if there is central crusting, then what is the disease which you need to remember? It is leishmaniasis. Which you need to remember. Okay, so here you can see the lupus vulgaris center will be showing atrophy or scarring. Tinea corporis, the center is going to show clearing, and in the leishmaniasis, remember center will be having crust. So annular lesions are seen in all except. So this was a recent MCQ. Please remember. Tinea corporis has annular lesion. Pityriasis rosea, Harald patch has annular lesion. Porokeratosis also has an annular lesion. I will show you what it looks like in the miscellaneous topic. Again, we are going to discuss it. Please remember, in the case of urticaria, we have what are called as wheals. We have the wheals which do not have this annular configuration. So these are the wheals, they do not have this annular configuration. So answer here is going to be option C. Okay, so next we have lines in dermatology. You need to know two important lines which can be even asked as images. Okay, so what are those lines? One are Blaschko's lines and the another one are Langer's lines. So let us discuss about the Blaschko's lines. Basically, simple funda is Blaschko's lines cannot be seen in a normal individual. Okay, Blaschko's lines are going to become visible only in certain diseases, dermatological diseases. Okay, so what are these lines? Basically, they are nothing but the pathways of the epidermal cell migration during the embryonic development. Okay, and remember one more point, these lines are not going to cross the midline. They do not cross the midline, and these are not going to correspond. They do not correspond. Very, very important. The arteries, veins, and the nerves. Arteries. No, these Blaschko's lines are not any nerves. They are not going to follow the lymphatics. They are not going to follow the arteries or veins or no other structure. These are just plain lines which are going to be imaginary lines which are going to be appearing during the embryologic development and will be only appreciated visible in certain dermatological diseases. You need to remember what is the pattern, what is the shapes of these lines in different areas. So remember, they are going to be spiral. So are you able to see this is a scalp? Over the scalp, you are able to see that they are spiral. And over the abdomen, they are having S configuration. So you are able to see this is the abdomen where they are appearing like a S. Over the upper spine, they are having this V type of appearance, and over the extremities they are linear in nature. Please remember, the Blaschko's lines are very, very important for you to identify. And over the abdomen they are S-shaped. You can remember that with the help of this black Superman, who is having this S symbol over the anterior aspect. Okay. Black coastlines, black. You can remember this shape, because in the exam you are going to be shown the images and also you should identify these lines. This portion of this scalp is also going to help you to identify this black coastlines, which is spiral. You are able to see that spiral nature of these lines is present. And this is the important disease in which we can see the Blaschko pattern. We call, whenever a disease is there, if the disease is following Blaschko's lines, we call it as Blaschkoid pattern of the lesions. And the disease name is, I hope you all might have heard it, incontinentia pigmenti, which is a very peculiar inheritance pattern. X-linked dominant inheritance is there. And you are able to see that the lesions in incontinentia pigmenti are appearing. So you can see here, they are appearing in a linear fashion over the extremities. Here you are able to see linear fashion over the extremities, and you are able to see that it is also having some whorled pattern. So you should also remember one more term which is used to describe these lines is whorled pattern or wavy pattern. So you can see that over the chest, these lines are having wavy pattern, and you are able to see that there is hypo or depigmentation over the skin, which is, all these are the different stages of this same disease, incontinentia pigmenti. We'll discuss this again in the miscellaneous topic. And the next type of lines are Langer's lines. Langer's lines, which are also called as skin tension lines, or they are also called as relaxed skin tension lines. So this was there in one of the options in the INSCT exam. Please remember, these lines are going to correspond to the collagen fiber orientation in the dermis. And what is the applied aspect of this whenever you are going to become the surgeons? Yes, I hope all of you are going to get the PG seats and you do not have to again watch these videos, man. And also you might be a surgeon, future surgeon, or gynecologist or ENT surgeon. So whatever it is, please remember, whenever you want to give an incision, always try to give the incision along the Langer's lines or at least parallel to the Langer's lines. Why? Because if anyone gives an incision perpendicular to the Langer's lines, then what happens? There is a high likelihood that the lesion is going to heal with a very bad scar. Okay, that is the reason why, remember, incision should be along or parallel to these lines. Healing will be better without any scarring if you do so. And how can you identify these Langer's lines? Very simple, very simple. So who is this character? It is Lord Thanos. So isn't it? So L for Lord Thanos, L for Langer's lines. So how can we remember the Langer's lines with the help of Thanos? So if you observe carefully, this portion of the face is having the orientation as if we can see in the Langer's lines. So with the help of that, you can remember Lord Thanos Langer's lines. And one more thing which you can see here is, in Langer's lines, there will not be any midline demarcation. These lines can cross the midline and move from right to left, left to right. Okay. Next, we have diascopy. So we dermatologists do not have this, stethoscope or any other equipment which other specialties have. We have only few of the things which we carry with us in the OPD. One of them is simple glass slide. So if a patient is coming with erythema over the skin, oh my God, doctor, it is red. Oh my God, doctor, it is red. So how can we differentiate between the normal erythema due to the dilatation of the blood vessels and the another type of petechia, purpura, ecchymosis, which will appear red in color? So how can you differentiate? Simple, apply the pressure with the glass slide. So this is the glass slide. If you apply the pressure, if the redness is due to the dilatation of the blood vessels, then what will happen? The blood vessels will be constricted, vasoconstricted. So we can see this whitish change of the skin, which is technically called as blanching. It is called as blanching. Okay. This, because we are applying pressure with a glass slide, we also call it as vitropression. Vitro is glass, pression is pressure. I hope you remember in vitro, in vivo. In vitro is in the glass slide, petri dishes. Okay. So this is the erythema. So we have seen in the previous picture where there was redness which was disappearing, which is called as blanching. Okay. So in the case of petechia, purpura or ecchymosis, remember there will be extravasation of the red blood cells. There will be extravasation of the red blood cells, red blood cells. So basically we are going to see that the redness will be persisting. If you see, this is a glass slide, the redness is persisting here because it is RBC which is extravasated into the skin. Okay, this is another picture where you are able to see that the erythema is persisting. So this is purpura or petechia or ecchymosis, okay, depending upon the size. So what is the next use of diastrophy? We can also use it in certain granulomatous disorders, So please remember, there are 3 important granulomatous disorders which you need to remember. So most important one is, of course, cutaneous tuberculosis, lupus vulgaris. And apart from that, sarcoidosis, you might have read this in your medicine by Dr. Dilip sir, and also leishmaniasis, which we'll again discuss. So in these 3 conditions, if you see, the one common thing is all these are going to be having granulomas in the skin. So if we apply the glass slide, what happens is, if there is a erythema component, that is increased blood supply, if it is there, that will be blanched, and we can see the granuloma in the form of this color which you are able to see. This is described as apple jelly nodule. So basically we can see golden brown color, which is described as apple jelly nodules, and this is basically due to the erythema which is disappearing on application of the pressure with the glass slide. So next instrument which we have in dermatology is Wood's lamp. So we are going to get a blue light emitted from this Wood's lamp, basically, which is going to have the wavelength. So it is going to have a filter which will filter out rest of the other wavelengths, and it will only allow the wavelength of 365 nanometers, 365 nanometers. You can remember approximately number of days in a calendar year. And what is it filter made up of? That is also very, very interesting. NOBS, nickel oxide barium silicate. So NOBS, no BS, no bullshit. Okay, do not allow any bullshit to pass through this filter. Only and only 365 nanometers will pass. And are you able to see that here there is this famous personality who is Vijay Mallya, and why does he wear the goggles? So that he wants to avoid any BS. Okay. So this is a filter which he's wearing. But why am I telling you this in the Wood's lamp? Because he always makes these Kingfisher calendars. So with the help of this, you can remember 2 things at one go. So the filter will not allow any BS, nickel oxide barium silicate, NOBS, and also you can remember the wavelength as 365 nanometers. Why? Because he makes the calendars. And who is this person? This is, I hope you might have seen this latest movie in which Nikhil was the hero, related to Sri Krishna. Yes. So this is nickel oxide. You can remember why? Because some students were confusing it with nitrous oxide. It is nickel oxide and barium silicate. And if you observe, he is also wearing the goggles to avoid any BS. So related to this Wood's lamp, you need to remember there are various colors, which that is a fluorescence. We call it as fluorescence, which we can see in various disorders. So in the tinea capitis, we have microsporum, which is going to produce this blue-green fluorescence, and trichophyton Schonlein, which is associated with the favors. It is going to show dull blue fluorescence on Wood's lamp examination. And pityriasis versicolor, it is a superficial fungal infection in which we can see yellow fluorescence. Okay, yellow fluorescence. And erythrasma, I hope you all remember, erythrasma is due to Corynebacterium minutissima, in which we can see coral red fluorescence. So Corynebacterium, coral red fluorescence, and yes, it is red in color. You can remember erythrasma. Eryth is red. And in vitiligo also, you can remember there will be milky white fluorescence. So this is the pityriasis versicolor, in which we can see very, very dull, very, very mild yellow fluorescence. So this is a blue background. I hope you are able to see that. In that blue background, there we can see some yellowness, some redness, as you are able to see. Here it is erythrasma, where we are able to see this coral red fluorescence in erythrasma. And this is a vitiligo. In vitiligo, what will happen? There will be exaggeration. There will be exaggeration of this white color on application of the wood slab. This is the cytodiagnostic test. You might have read this in your microbiology, which is called as Zang smear. Very, very important. This is being asked of late very, very interestingly and integrated fashion with microbiology as well as dermatology. So you need to know about this. So basically, whenever we see any vesicular-bullous lesion over the skin, what we are going to do? We are going to remove the roof of that lesion, and we are going to scrape the base of that lesion, and we are going to put it on the glass slide, apply giemsa stain, and observe it under the microscope. What we are going to see? We are going to see the cells. What are those cells? First one is acantholytic cells. Very, very important. So I hope all of you do remember the causes for acantholysis: pemphigus, bullous impetigo, staphylococcal scarlet skin syndrome, Hailey-Hailey disease, Darius disease, and also viral infections, herpes infection. So in herpes as well as pemphigus, we can see this acantholytic cells. So this is the acantholytic cell which you are able to see. It's a round cell which is having central hyperchromatic nucleus and a perinuclear halo. So this is basically a keratinocyte. Okay. Next type of cells which we can see, very, very important. This was also asked recently in the FMG exam, multinucleated giant cells. So basically these are also nothing but the keratinocytes. So here what happens is a group of keratinocytes will merge together and they will appear as a single cell. But because many keratinocytes are merging together, so there will be multiple nuclei present in these cells. So that is the reason why it is called as multinucleate giant cells. And these cells are seen in herpes simplex viral infections and also in the varicella zoster virus infection. That is in varicella and also in herpes zoster, we can see the multinucleate giant cells positively. Next, we have some therapeutic procedures. Okay, first one which you are going to see is cryotherapy. So therapy with crying is called cryotherapy. No, cryo is cooling. Okay, if we treat the lesion with the help of cryo, that is cooling, then we call it as cryotherapy. And what is the agent which you are going to use? So this is the cryo gun, inside which we'll put liquid nitrogen which has a temperature of minus 196 degrees Celsius. And this is going to cause the death of these cells which are infected by various viruses because of the freezing. And what are those viral infections? Remember, we can use it in warts, we can use it in molluscum contagiosum, and also we can also use it in keloids. Where we are going to destroy the unnecessary tissue which is being grown. And next we have the phototherapy. So what is phototherapy? By clicking a selfie we can treat a lesion? No. Phototherapy basically means usage of the ultraviolet rays. So what are the ultraviolet rays? We are going to use UVA as well as UVB. We are going to use UVB and also UVA. So in the UVB, remember, we are going to use very, very narrow wavelength of UVB. We call it as narrow band ultraviolet B radiation, and the wavelength unit, remember, it is 311 plus or minus 2 nanometers. Whereas in the UVA, remember, we usually give this in combination with the P. What is P? It is psoralen and UVA. So we call it as PUVA therapy. PUVA therapy, and here the wavelength is 320 to 400 nanometers. And basically, what is this psoralen? Psoralen, it is basically a photosensitizer, which can be given both in topical lotion form and also it is available in the form of tablets. And this is a phototherapy chamber into which the patient has to go inside to get the therapy. What are the indications? You can remember, very important, psoriasis, vitiligo. Previously, MCQs were asked on these two, and also atopic dermatitis also we can use this, which is basically a form of eczema. So now let us look at the lesions in various vesiculobullous disorders. So we are going to discuss the vesiculobullous disorders. You need to know that clear fluid-filled lesions which are less than 1 centimeter, they are called as vesicles. And if they are more than 1 centimeter, we call them as bullae. You can see the vesicles. So this is the vesicle which is less than 1 centimeter in size, and this is a fluid-filled lesion which is more than 1 centimeter, which is called as a bullae. And how are these bullous disorders classified? If there is underlying autoimmunity because of which vesicles and bullae are forming, we call it as immunobullous disorder. If there is a mechanical injury after which there are bullous lesions produced, we call it as mechanobullous disorders. And there are two important diseases which are inherited acantholytic disorders, which you need to remember. So we are going to discuss all this. So first, coming to the immunobullous disorders, where there will be underlying autoimmunity because of which there will be split in the skin, and in this split there will be fluid getting accumulated. What are the two important broad classification which you need to remember in the immunobullous? So if the split is present inside the epidermis, we call it as intraepidermal blistering disorders. We can also remember them as superficial blistering disorder. If the split is happening below the epidermis, then we call them as subepidermal blistering disorder, where the split is going to be deeper. Okay, so the important diseases which you need to remember associated with the intraepidermal blistering disorders are pemphigus group. So here you can see I have written yes like this. Why? Because in the intraepidermal you can remember yes for superficial and yes for pemphigus group of disorders. And in the subepidermal also, if you observe carefully, D in deeper is corresponding to the pemphigoid and dermatitis herpetiformis. So with the help of these, you can remember what are all the important diseases which are associated with the intraepidermal blistering disorder and subepidermal blistering disorder. So first, let us quickly see the pemphigus group of disorders, in which we have to remember two important conditions. One is pemphigus vulgaris and the another one is pemphigus foliaceus. Remember, wherever you hear this term vulgaris, it simply means it is the most common form of that disease. So pemphigus vulgaris is the most common form, and you need to also remember pemphigus foliaceus and its features. So what is the common thing to both these conditions? So both these are the immunobullous disorders in which IgG is having an important role. It is responsible for the autoimmunity, and there will be a intraepidermal split, and the target protein is going to be desmosomes. I hope you remember in the acantholysis we discussed. So the connections of the keratinocytes is going to be lost, and there is going to be, yes, acantholysis. Acantholysis is the term which you need to remember. So this picture you all know already. So in the pemphigus foliaceus and vulgaris, the difference is going to be in few antigens which you need to remember. Remember, in pemphigus foliaceus, F for foliaceus, the antigen which is going to be targeted to which antibodies are produced are desmoglein first. So foliaceus and first, you can remember with the help of this F for foliaceus and F for 1, desmoglein 1. And coming to the pemphigus vulgaris, remember in pemphigus vulgaris, I hope you all know whenever we talk about anything vulgar, what is the 3-letter word which you can remember? I hope all of you know that. So 3-letter word, so desmoglein 3 is going to be the antigen against which antibodies are produced, and also we can see antibodies against desmoglein 1 also, but 3 is very, very important in pemphigus vulgaris. You need to remember that. Okay, so I hope all of you know, whenever anyone wants to be number 1, rank number 1, that is they want to be in the top. Okay, top means not total top, it is top of the list of the ranks. So likewise, you should remember that in the skin and the mucosa, the expression of these desmogleins is different. So DSG is desmoglein. Desmoglein 1 is present more concentrated in the superficial layers of the epidermis, that is, we can say stratum corneum. Okay, because it is first. And desmoglein 3 in the skin, remember, it is present in higher concentration. It is expressed in higher concentration in the stratum basal. So I can remember that, just put one line here. So how does it appear? It is appearing like alphabet B. Okay, so desmoglein 3, 1 and 3. So in the mucosa, very interesting thing, M is appearing like this. So if it gets sleep, what will happen? It will fall like this. It will fall like this and it will appear like 3. So in the mucosa, remember, desmoglein 3 is present in higher concentration, and you can as well remember, for all practical purposes, desmoglein 1 is almost absent in mucosa. Okay, so what is the clinical significance of this? I hope you might be able to connect the vulgaris and the foliaceus and the expression desmoglein. So please remember, desmoglein 1 is present in upper epidermis and the oral mucosa, low concentration or almost absent. Desmoglein 3 is present in the lower epidermis. I hope you all remember this B trick basal, and yes, in the mucosa it is high concentration. So now combine both this concept. So what do you get? Please remember in the Pemphigus foliaceus. So we have antibodies against desmoglein 1. So the split is going to be, the damage is going to be in the stratum corneum. So there will be a split happening in the stratum corneum, below the stratum corneum. We call it as subcorneal split. And remember, in the mucosa, no lesions will be there in Pemphigus foliaceus because desmoglein 3 is absolutely normal in foliaceus. Coming to Pemphigus vulgaris, very, very interesting. So desmoglein 3 is the antibody which is produced. So there will be very, very important mucosal involvement. In fact, more than 95% of the cases are going to have a mucosal involvement, oral mucosa most likely. And also the split is going to be present in the stratum basal or above the stratum basal. So we call it as suprabasal split in the case of Pemphigus vulgaris. So clinically, how can we appreciate the acantholysis? Can we appreciate? Yes, we can. So there are certain signs clinically which we can demonstrate. So what are those things? Very, very important. Nikolsky sign. You need to remember this Nikolsky sign. Apart from this, we have Asbo-Hansen sign and Bulla spread sign. And laboratory also helps us to identify this acantholysis. What is it? So basically, we can do a biopsy, but before biopsy, what we can do? Yes, cytodiagnostic Zang smear can also be done. So now let us look clinically. How can we identify whenever a patient of vesiculobullous disorder, any vesicles and bullae if they are present? What we can do is so the adjacent to the vesicular bulla, just we have to apply the tangential pressure on the normal skin. Okay, adjacent normal skin. Then what happens if there is underlying acantholysis? There will be separation of the upper layers of the epidermis from the lower layers. So this is what is called as Nikolsky sign. Nikolsky sign, very, very important. We can see Nikolsky sign whenever there is underlying acantholysis. Otherwise, Nikolsky sign will be absent. So Nikolsky sign is only seen in conditions where there is acantholysis. Otherwise, Nikolsky sign will be negative. So you can see here the superficial layers of the epidermis, they are getting separated from the underlying dermis. And next is bulla spread sign, in which we select a bulla. Okay, and we will apply a lateral pressure. So we will apply a lateral pressure over the bulla. So you can see here we have selected this bulla, and you can see there is a pen marking here. There is a pen marking present at the periphery of this bulla, and we apply a lateral pressure. Then what will happen? This bulla will spread onto the adjacent normal skin. So you can see here the pen marking is visible, but here the pen marking is not seen. Here it is not seen. The reason is the bulla has spread to the normal skin, adjacent normal skin. So if you see this lesion from the side, so this was the initial lesion. So we have drawn the pen marking here. So after application of pressure, what happened is the bulla has spread to the surrounding normal skin. So what happened? The pen marking has gone into the roof of this bulla. So it is not appearing clinically here. This is a bulla spread sign. Okay, or it is also called as Asbo-Hansen sign. Okay, next topic which you need to know is the differences between the clinical differences between the intraepidermal split lesions and the subepidermal split lesions. So in the intraepidermal split, I hope you all know the disease which you need to remember is Pemphigus. And in the subepidermal, the important disorder which you need to remember is pemphigoid. Okay. So in the intraepidermal split, what happens is the roof is going to be comparatively thin, and that is the reason why we can see flaccid bullae in the case of the intraepidermal split. Flaccid bullae. Why are they called flaccid? Because if you observe carefully, there will be wrinkling present on the surface of this vesicles and bullae. Whereas in the case of subepidermal split, the roof is going to be comparatively very, very thick, and we can see tense bullae present. And wrinkling will not be present in this. So you can see this is the tense bullae present in the patients of pemphigoid. There is no wrinkling on the surface. So how can you remember this? I hope you all have seen this movie. This is from the picture Sholay. And Burana Mano Holi Hai is a very famous dialogue. Burana Mano Holi Hai means do not take it bad. This is a holy, so whatever we do, you have to accept it. Holy hai. Okay, so in this, why am I telling you this here is because Burana Mano Holi Hai, you can remember Bullas, Fempicoid. Why is this? Why am I telling you all this? Because if you observe carefully in this next slide, you can see that Goga sir is celebrating the Holi, and what are you able to see in front of the Goga sir? You are able to see there are so many gubbare, balloons which are filled with the fluid, with that is a color of water, and you are able to see that they are very tense, very tense. So in the holy time, remember these balloons, remember Burana Mano Holi Hai. In Bullas Fempicoid, we are going to see the very tense bulle. This is what I want all of you to remember. Very important. Flaccid bulle are seen in intraepidermal split, and tense bulle are seen in subepidermal split. Very. So coming to the pemphigus vulgaris, the disease progression. So remember, primary lesions are going to be flaccid bullae, which are present over the normal skin. And once these lesions rupture, they are going to leave behind the erosions. And one very peculiar characteristic of the lesions in the pemphigus is the erosions are going to extend. They tend to extend onto the surrounding normal skin. They tend to extend, and there is no tendency to heal. So this is a very bad thing for the patient. This is the reason why the patients previously, before the advent of the steroids, they used to have a very bad prognosis. So to say, mortality used to be very high. Okay, and what are the sites which can be affected? So oral mucosa is the most important site, which is usually the initial site of involvement, and afterwards any area of the body can be affected. So this is how the presentation will be in the buccal mucosa as well as in the gingiva. So in everywhere in the mucosa there can be the erosions, and there is every possibility the treating physician might treat it, this is just a aphthous ulcer, but what happens is patient will come again and again with the same complaints despite we giving oral steroids, topical steroids, I mean to say orally topical steroids. There will not be any improvement, and one fine day the patient will present with the lesions over the skin. So this is how the presentation of pemphigus vulgaris will be seen. So there will be some vesicles, some bullae. So here you are able to see that there is a wrinkling over the surface. This is a flaccid bullae, and most important thing is seen at the center. So here you are able to see that there are erosions which are produced, and these erosions are tending to extend. There will not be any tendency to heal, and one fine day, if the patient is not taking any treatment, there is every likelihood that the patient will appear as if he or she is a patient of burns. Okay, so much extension can be seen over the body. So very important condition to diagnose and to treat immediately. Now coming to the lab Zang smear and histopathology. Zang smear, I hope all of you do remember that we are going to see acantholytic cells in the pemphigus vulgaris. And coming to the histopathology, what we are going to see? Yes, if you take histopathology, we can see this very important finding, which is called as row of tombstone appearance. So I will tell you what is this. First of all, remember, we already know that in pemphigus vulgaris, it is desmoglein 3 more than 1, and 3 is present in the stratum basal. So suprabasal split will be there. So what is the suprabasal split? So in this image, this is a stratum corneum, this is stratum granulosum, this is stratum spinosum, this is a stratum basal. So you are able to see that the stratum basal is attached to the underlying dermis or dermoepidermal junction, and there is a split which is above the stratum basal. So it is called as suprabasal split. And yes, this is having one very important significance in histopathology. Remember, we have seen this. I told you to remember this also. Hemidesmosums are going to help in the connecting stratum basal cells to the underlying dermoepidermal junction. But in pemphigus, hemidesmosums do not have any antibodies. So what happens is the stratum basal cells are going to be still attached to the underlying. So the hemidesmosums, they are going to help in connecting the stratum basal to the underlying dermoepidermal junction. So the stratum basal cells are going to be still attached to the underlying dermoepidermal junction, and this is the reason why we are going to get this observation which is called as row of tombstone. Row of tombstone appearance. So here you are able to see this is the stratum basal cells which are attached to the underlying dermoepidermal junction, but they are separated from one another. So we can describe these cells as basal cells, stratum basal cells, which are laterally detached with one another, but they are vertically attached. And this is because of the hemidesmosomes are helping in attachment of the stratum basal cells to the underlying dermoepidermal junction. So this was recently asked in the exam in the form of a assertion reason question. So assertion reason question. So clinically, patient having flaccid bullae with painful erosions will show suprabasal split and inflammatory infiltrate in the blister cleft on histopathological examination. Okay, that is statement 1. And row of tombstone appearance is diagnostic of pemphigus vulgaris. This is statement 2. So this is, we can say, assertion reason type of question. So if you observe carefully, both the statements are true. So clinically, patient with flaccid bullae, you can think of it as a intraepidermal blistering disorder. So there will be erosions will be there, suprabasal split will be there, and blister cleft may have inflammatory infiltrate. So row of tombstone appearance is also seen in pemphigus vulgaris, but what is the important thing you need to remember is there is no relation between these two. If the examiner has given row of tombstone appearance is present in pemphigus vulgaris, and in the statement if it was given as hemidesmosomes help in attaching certain basal cells to the underlying dermoepidermal junction, it would have been correct assertion and reason is actually describing the assertion. That would have been the answer. So here the answer is going to be both statements are true, but 2 is not explaining the assertion 1. Now coming to the DIF, which is very, very important, investigation of choice in the vesicular bullous disorders topic. So DIF, direct immunofluorescence. So in pemphigus vulgaris, what we are going to see, IgG and C3 are going to be deposited intraepidermally, because of which we are going to have this peculiar fish net or chicken wire pattern. This is also described as intercellular deposition of IgG and C3. So here you can see this is described as chicken wire pattern because it is appearing like a chicken wire, the fluorescence which is appearing in the epidermis. And here you are able to see this is the demarcation between the epidermis and the dermis, and you are able to see that it is appearing like a fish net. So that is the reason why it is also described as fish net. Coming to the treatment, very, very important. The treatment of pemphigus vulgaris should be very, very meticulous, and it is going to be with the mainstays systemic steroids. And also we are going to use the other steroid sparing agents, like for example cyclophosphamide. The problem with cyclophosphamide is the development of hemorrhagic cystitis, and we can also use the treatment of DCP pulse, dexamethasone cyclophosphamide, in the form of pulse therapy, where we are going to give suprapharmacological doses of the dexamethasone and cyclophosphamide for 3 days. And we are going to call the patient again after 27 days, and we are going to again give this pulse therapy. So, okay, this is how the treatment of pemphigus vulgaris should be. It is very, very dangerous condition, so the treatment also should be very aggressive. And off late we are having monoclonal antibody which is produced, which is rituximab. It is a FDA approved drug which is basically going to act on the B cells, okay, B cells, precisely CD20. So thereby it is going to reduce the production of the antibodies by the patients of pemphigus vulgaris. So this is a medication, rituximab. It is a very costly medication. Monoclonal antibodies are very costly. So now we are going to discuss the subepidermal immunobullous disorders. So pemphigoid, bullous pemphigoid, and dermatitis herpetiformis. Important is bullous pemphigoid. So pemphigoid group, the defect is going to be in the basement membrane zone proteins. So it is also called as DEJ, dermoepidermal junction. So I told you this is an image. So let us quickly see what is this image. So this is the stratum basal. And these are the keratin intermediate filaments which I told you in the basics topic. So this is basically keratinocyte. So we are looking in the cut section. So in the keratinocyte, there will be KIF. Remember, in the stratum basal, the keratin intermediate filaments which you should remember are K5 and K14. Very important. And this is the hemidesmosome complex. Hemidesmosome complex. And we have below the stratum basal. Now we are talking about the junction between the dermis and the epidermis. So we have lamina lucida, and below which we have lamina densa, and below which we have sublamina densa. Okay, lamina lucida, lamina densa, and sublamina densa. So what is the clinical significance of this? There are various diseases in which there will be antibodies or there will be genetic defects in the proteins of these layers. So remember, I told you keratin intermediate filaments, the number which you need to remember is keratin 5 and 14, K5 and K14. And also hemidesmosome, remember we have BPAG2 and BPAG1. What is BPAG? BPAG stands for bullous pemphigoid. Antigen 2 and BPAG1, bullous pemphigoid antigen 1. Okay, so coming to lamina lucida, lamina densa. Remember, laminin will be common here because lamina lucida, lamina densa, laminin will be there. In the lamina lucida, remember BPAG2 will be present. BPAG2 will be present. And in the lamina densa, remember D is the fourth alphabet. So collagen. Okay, so in the dermis, we all know collagen is present. So collagen 4 is going to be present in the lamina densa. A, B, C, D, 4. Okay. Fourth. And in the sublaminar densa, remember we have collagen 7. Collagen 7. And how can I remember this? 7 starts with S, and sublaminar densa also has this alphabet S. And it is also called as, remember other name is also important, anchoring fibrils. Anchoring fibrils, FIBRILS. 7 alphabets, collagen 7, sublaminar densa. So all these are very important. Okay. So now coming to bullous pemphigoid. Bullous pemphigoid, remember it is an immunobullous disorder. We all know that. And the split is going to be subepidermal. It is deeper, isn't it? Subepidermal split will be there. Here the antibody is going to be IgG, which will be deposited. Where it will be deposited, I will show you in the images in the direct immunofluorescence. Okay. So the target protein is hemidesmosome. Very important. And precisely it is BPAG2 more than BPAG1. BPAG2 more than BPAG1. And remember, this is a happening below the epidermis. So acantholysis will be absent in this. No acantholysis is seen in this disorder. Coming to the clinical feature, remember the age group is going to be elderly, 60 to 80 years aged, males or females. It is equal in incidence in both males and females. How does it manifest? Primary lesions, I hope all of you remember the Buranamana Holy Hair story which we have discussed. Bulle will be tens bulle. So tens component, I hope all of you remember. Now see, the lesions are pruritic. Okay, remember in bullous pemphigoid, the lesions are going to be associated with itching. Okay, itching. And the lesions, the tens bullae here are going to be present on the normal skin, or they can also be present on erythematous skin. This is also a very important point. Okay, erythematous skin, and this erythema is because of the wheal. The skin is going to have a wheal flare response over which a tens bullae can be produced, and this wheal is responsible. This wheal is responsible for the itching which is seen in these patients. And remember, the cells which are seen in the lesion are eosinophils. 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 Okay, very, very important to know all these points. And of course, one more point which was recently asked. Remember, bullous pemphigoid is associated with programmed cell death 1 targeted inhibitors, like for example nivolumab and pembrolizumab. This was not asked as a separate MCQ of pharmacology, but in the case scenario they have told a patient who is using the nivolumab has now developed the tens bullae. So what could be the diagnosis? Like that question was asked. So do not worry. You need not remember the medication names as such, but remember that yes, nivolumab and pembrolizumab are associated with bullous pemphigoid. Okay, now yeah, bullae which are itchy nature will be there, so obviously the patient will scratch, so there will be erosions which will be developed, which will be left behind. And remember, unlike pemphigus vulgaris, in the bullous pemphigoid the patients are very very lucky. Why? Because the tendency to heal is present in bullous pemphigoid lesions, and there will not be any tendency to extend onto the normal skin. This is one very very important and what we can say a lucky thing, because of which the patients of bullous pemphigoid have very very good prognosis. Remember this, even if we leave the patient without any treatment, there is a high likelihood that the condition may self resolve. So this is ironical, man. We may think, "Arey yaar, pemphigus vulgaris is superficial. Bullous pemphigoid is deeper, man. This is going to have a very bad prognosis." This is what we think, but what is actually happening is exactly opposite. So pemphigus vulgaris is a very very dangerous condition, whereas bullous pemphigoid is chalta. It's a light condition. And also remember, mucosal involvement might be there. 10 to 30% of patients may have mucosal erosions involvement. In the skin, yes, I have told you tense bullae, that is one point. And where are you able to see this tense bullae? So if you observe, the skin is red, there is wheal present. Okay, and what is the next picture showing you? There will be a very very good healing. Are you able to see this beautiful healing? There is no tendency to extend. There is very very good healing. Okay, and one more term which you need to remember is these, bullae, they will be, if they are not scratched and if they are not forming erosions, the fluid is going to be absorbed and the bullae are going to settle down. So here you are able to see, this is the tense bullae which you are able to see, tense bullae, and here you are able to see that these bullae are settling down because of the absorption of the fluid, and these are called as settled bullae. So just remember, settled bullae is a concept associated with bullous pemphigoid. And as I have already told you, I hope you remember, Nikolsky sign is going to be seen conditions where there is acantholysis. And remember, acantholysis is due to suppression of the keratinocytes. Where are keratinocytes present? They are present in epidermis. So in conditions which are going to have intraepidermal split, like for example pemphigus vulgaris, we are going to have acantholysis, so Nikolsky sign will be positive, whereas bullous pemphigoid is a subepidermal blistering disorder, so Nikolsky sign will be negative. Very very important point. Bullous spread sign, Asbjornsen sign, both of them can be present in the subepidermal or intraepidermal blistering disorder, so it will not help us to differentiate between these two. So what is Asbjornsen sign? Basically, if the bullar vesicle is very very small, what we will do is we'll apply the perpendicular pressure. So then there will be again extension onto the normal skin. This is what is called as Asbjornsen sign. Okay. Now again, investigations. Okay, wherever we see the fluid filled lesions, we should do these investigations. First one is Zang smear, simple bedside test. This can be done on the bedside also. Next, biopsy and DIF. So in the Zang smear, what is the finding? No acantholytic cells. Very very important. There will not be any acantholytic cells. Absence will be there, and there will be eosinophils. I told you, eosinophils are responsible for the wheal and pruritus in bullous pemphigoid. Next is histopathology. What we can see on histopathology, very simple. Okay, so in the pemphigus vulgaris, the roof was a little bit thin because stratum basal was still attached to the underlying derma-epidermal junction. But in bullous pemphigoid, stratum corneum, stratum granulosum, stratum spinosum, stratum basal, everything forms the roof. Okay, so the roof is very thick, and you are able to see that there are some cells present in the split. So here is a split. Maybe these are eosinophils. You need not identify these cells. They might be eosinophils. Okay, we cannot see acantholytic cells in this condition. So DIF, very very important. What are the antibodies? Same like the pemphigus vulgaris, IgG and C3. So how can you differentiate? Now the pattern of the immunofluorescence is very important. So it is now going to be along the basement membrane zone, or dermoepidermal junction, and the pattern is going to be linear. Okay, this is what is very important for you to remember. If you are given a picture, see how is the fluorescence. So in this picture, you are able to see that this is the epidermis and this is the dermis, and you are able to see that the fluorescence is present all along the basement membrane zone in a linear fashion. So this is bullous pemphigoid DIF finding. DIF is investigation of choice. Very, very important. And I have told you already, bullous pemphigoid is going to have a very, very good prognosis. So topical steroids may be sufficient, or at the most we can give low dose oral steroids if at all required. So next conditions are pemphigoid gestationis and linear IgA bullous dermatosis. Okay. Pemphigoid gestationis, remember, it is bullous pemphigoid which occurs in pregnancy. So basically we can remember it is a BP which occurs in pregnancy. And linear IgA bullous dermatosis, which is in short called as LABD. In children, this is having a different name. It is called as CBDC. Okay. Chronic bullous dermatosis of childhood. And in the adults, the same condition is called as LAD, linear IgA disease, or we can also call it as LIGA, linear IgA disease. Okay, so these are the names. So coming to the pemphigoid gestationis, please remember the other name of this condition is, it is also called as herpes gestationis. Now pemphigoid gestationis name is understandable. So bullous pemphigoid in gestational period, that is pregnancy. So pemphigoid gestationis. But why the hell do we use herpes gestationis? Isn't it a misnomer? Yes, it is a misnomer, but what we can do in the books, it is already written like that. So please remember, it is not a viral infection. It is just the other name of pemphigoid gestationis. And please remember, it is a bullous pemphigoid which occurs in the pregnancy. Here again, the target antigen is BPAG2. So how does it present? So if it is like a bullous pemphigoid, so it will also have tense bullae, which will be present on urticarial plaques. Now the site is very important in pregnant women. The site is periumbilical. This is very important to remember. Periumbilical region will show these tense bullae on urticarial plaques, and there can be a possibility of extension onto the adjacent thighs and abdomen. And treatment is going to be, because the patients are in pregnancy, systemic steroids are safe and they are the drug of choice in these patients. So this is the herpes gestationis, which is extending onto the thighs. Next, we can see CBDC, which is very important. Chronic bullous dermatosis of childhood. So here the autoimmunity is going to be IgA. So basically, if you can remember, the adult form of this condition is called as linear IgA disease, isn't it? So then you can remember it is IgA. Very, very simple. But in the children, the name is CBDC. So you need to remember the autoantibody is IgA. And the morphology is also very, very interesting and important. Remember, the lesions of CBDC are annular. So what is annular? I hope all of you remember. Different center, different periphery. Okay. So the center is going to be like this, whereas in the periphery, you are able to see some important finding. What is that? There are vesicles. So all these are vesicles which are studding, which are present studded at the periphery. So this is described as, because they are appearing like pearls or jewels, it is described as cluster of jewels or string of pearls appearance. Cluster of jewels or string of pearls appearance. Basically, there are vesicles which are present at the periphery. So it is appearing just like this. So it is described as cluster of jewels or string of pearls. So in the actual image of CPDC patients, you can see this is one annular lesion where you are able to see the vesicles which are present studding at the periphery. And distribution is perioral and perineum, and the treatment is going to be with beautiful medication, dapsone. Very, very important. So now you might be wondering, sir, in linear IgA bullous dermatosis and also in bullous pemphigoid, we can see the linear pattern. So how can we differentiate both of them? So please remember, in bullous pemphigoid, what was the deposition happening of antibody? It was IgG. Whereas in linear IgA disease or CBDC, it is IgA. So how can I remember this IgA, man? So just if you know Elizabeth, Queen Elizabeth, you can remember this point. So Eligabeth, okay, Eligabeth, Liga, okay, Liga. And why is this, picture of the Elizabeth have kept here. Why? Because you can remember the annular lesions which are having this cluster of jewels, a string of pearls appearance with the help of this. This is also called as crown of jewels appearance. So usually queens, they wear the crowns, jewels, pearls. You can remember with the help of Elizabeth, Liga. So linear IgA disease, chronic bullous dermatosis of childhood, we can see the cluster of jewels, a string of pearls appearance. And can you see this beautiful improvement after Dapsone? So this is before and after pictures of treatment with Dapsone. Okay, and you are able to say this is a linear pattern. So linear pattern does not make any sense. The examiner is going to give you whether it is IgG or IgA. Okay. So next we have this dermatitis herpetiformis, in which you have to remember some important points. First of all, the other name of this condition is also called as Dahring's disease. And in this, you should remember few important points. Chronically relapsing itchy subepidermal blistering disorder. Okay, where we can see the autoantibody IgA. And the target antigen here is epidermal transglutaminase 3. So you will again come across this name with the difference of number in the case of autosomal recessive congenital ichthyosis, which is lamellar ichthyosis. Remember this point. Okay, in lamellar ichthyosis, the target antigen, the antigen which is affected is epidermal transglutaminase number 1. Epidermal transglutaminase 1. Okay, so here it is epidermal transglutaminase number 3. So some HLA associations also you should remember, HLA DQ2 and DQ8. One second. Yes, DQ2, DQ8. And the one important systemic association which is very, very important for you to remember is celiac sprue. Remember, yes, it is also called as gluten sensitive enteropathy, but in the recent exam, the term celiac sprue was given. So you need to know celiac disease or celiac sprue are the other names for gluten sensitive enteropathy. Okay, and the patients of dermatitis herpetiformis might have asymptomatic nature due to this GI manifestation, or the patients may be having malabsorption, diarrhea, and abdominal pain. So these things also can be observed, or the patient may be absolutely asymptomatic. Okay, and now coming to the course. So chronically relapsing condition, we have already seen the patients are going to have itching. This is one very important observation. Why is it important? Because usually the patients are going to present with papulovesicular lesions. But because of this constant scratching, the papules and vesicles may rupture, and ultimately we can only see the erosions clinically. And why is this condition called dermatitis herpetiformis? Because the condition is extremely itchy, just like in dermatitis. So dermatitis term is used. And why is it called herpetiformis? Because the papulovesicles which we can see are going to be arranged in a grouped fashion. So that is the reason why grouped papulovesicles which are itching are present. So it is described as dermatitis herpetiformis. Okay. And what is the age group? It is seen in 20 to 40 years age group. Yeah, these are the papulovesicles which you observe, can be seen on clinical examination, and they are extremely itchy. Very important. Remember, in dermatology, there are some conditions which are extremely itchy. One among them is dermatitis herpetiformis. What are the others? So remember, lichen planus and scabies. These are the other conditions which are very, very, very itchy. So where are the lesions present? Very important. This is also an important PSR question. Extensor aspect. So you can see over the elbows, over the knees, the lesions can be present. And what are the lesions? They are grouped excoriations. Okay. I hope all of you know the excoriation marks are nothing but the scratch marks. Okay. So that is a costly dermatological. We always try to washify everything in dermatology. Okay, because of the constant scratching, itching by the patients, we can see this group excoriation marks present. Where are they going to be present? They are going to be seen over the extensor aspect mainly. Okay, so now coming to the investigations, Zang smear, biopsy, and DF. We are going to do in the Zang smear. Remember, we are not going to see any acantholytic cells. This is a subepidermal blistering disorder. So we can see neutrophils. So neutrophils can be seen. And what is the reason for this? Because there is a elevation of the interleukin 8. So now coming to the histopathology of this dermatitis herpetiformis, please remember the split is going to be subepidermal in nature, and we are going to see the papillary tip microabscess. So please remember, this is very important term to remember, papillary tip microabscess. So what is this papillary tip microabscess? So here you are able to see this is the epidermis and this is the papillary tip, and in the papillary tip you are able to see small split is present. That is first thing, split is present in the papillary tip, and you are able to see some cells are present. You need not identify these cells in the examination, but you have to remember that in the papillary tip we can see collection of the neutrophils. In case of dermatitis herpetiformis, this is called as papillary tip microabscess. Okay, papillary tip microabscess, very important. Okay, coming to the immunofluorescence, please remember we can see the deposition of the IgA, very important, IgA. How we are going to see this? So this is the epidermis, this is the epidermis, here we have this dermis, and you are able to see this is the papillary tip, and you are able to see the immunofluorescence is present in a linear fashion along the basement membrane zone, but that linear fashion is not important. So that is not described as linear fashion also. That is also one more thing which you need to remember. It is having some, it is not present in a continuous nature. It is having some gaps, or we can say it is discontinuous pattern. So we are going to call it as granular pattern of immunofluorescence. Very important. Granular pattern of immunofluorescence can be seen in the papillary tip as well as the basement membrane zone. Very important. Granular pattern. Small granules. Okay. So next, how can you differentiate this linear IgA disease from dermatitis herpetiformis? Because in both of them IgA is seen. So this is common, but the pattern is different. So in linear IgA disease is linear, whereas in dermatitis herpetiformis it is granular. Very important point. So how can you remember this granular pattern? So let me give you a simple trick. So in dermatitis herpetiformis, why is it called herpetiformis? Because there are grouped vesicles. Okay, so likewise grouped vesicles will be there and granular pattern of direct immunofluorescence will be seen. So with the help of that, maybe you can remember that granular pattern is seen in dermatitis herpetiformis. Okay, next is treatment. Very simple. Remember the association. You can remember treatment of choice. What is association? Celiac sprue. Celiac disease, gluten sensitive enteropathy. Avoid the food where gluten is present. What are the foods which are having gluten? Barley, rye, oats and wheat. Bro, you can remember it as bro. Okay, that is a treatment of choice. Avoid gluten diet. Barley, rye, oats and wheat. So remember, rice is safe. Rice will not have gluten, so it is safe. Whereas what is the drug of choice? Dapsone is a drug of choice. See, remember, wherever neutrophils are the cells, their dapsone is going to be the drug of choice. Okay. So remember, oats actually are not having gluten, but the problem is the processing is going to be done along with the barley, rye and wheat, because of which oats will get the gluten from them. So that is the reason why it is forming as a component of gluten diet. That is just to remind you, moral, our company decides our final destiny. Remember this very important points. Try to avoid the people who are going to give you demotivation or who have negative vibes with you. Okay. So next we have the mechanobullous disorders. Remember, very important, terms which are going to be given by the examiner. I will tell you, but remember mechanobullous, whenever you hear that, you should remember epidermolysis bullosa. You should remember epidermolysis bullosa. And what are the three types of epidermolysis bullosa? You need to remember: simplex, junctional, dystrophica. So these are the three types. I will discuss these in the next slides. Okay, but there is one more type of epidermolysis bullosa, which is epidermolysis bullosa acquisita. Remember, This has nothing to do with mechanobullous disorders. This is a different acquired condition, which is not a type of epidermolysis bullosa or mechanobullous disorder. Remember this one point. And yes, what is the clinical significance? Whenever the mother or any person handles a child, will they get any vesicles or bulla? Normally they will not get any vesicles or bulla. But in these patients, what happens is just the mechanical injury or mild friction over the skin also is going to produce blisters and bullae over the child. So you can see here, this is a child who is normally handled by the mother. But despite the child is smiling, you can see that the body is having so many vesicles and bullae. So unfortunate child of epidermolysis bullosa. And these are genetic conditions. Remember, genetic conditions will not have any antibodies. So DIF will be negative. Very, very important point to remember. And this picture I have shown you, I have explained. Now I just want to tell you what are the proteins which are defective in which type of epidermolysis bullosa. So there are three types: simplex, junctional, and dystrophica. So the simplex, remember, the defect is going to be in the keratin 5 and protein. So genetic defect of K5 and K14 will be there. Okay, so this is stratum basal cell, keratin 5 and protein. This is hemidesmosome. Okay, coming to junctional, there will be a defect in the laminin. Okay, now coming to the dystrophica, it will be very deeper. The problem will be deeper. It is collagen 7, that is sublaminar densa. Okay, right. And how does the examiner give you clues about mechanobullous disorders? Very, very important. There can be history of, because it is a genetic condition, a consanguineous marriage may be given or may not be given. This is not very important. Okay, and involvement of the sibling, previous sibling was also having the same lesions, may be given in the history. Okay, and most important, mother on handling the baby, wherever there is handling, mechanical trauma is there, there are vesicles and bulla induced. So this is one very important history which might be given. And in the investigations, remember, DIF will be negative because this is a genetic condition. Okay, and you can see that the child may have the vesicles and bullae or the palms and soles, and because of the condition being very, very chronic, the skin will show so much of changes that the fingers might be damaged and destroyed, leading to the development of what are called as mittens hands. Just like the mitten which we use to remove the utensils from the oven, so that will not have any fingers. Okay, just like that the hands of these children may turn. And what is the treatment which we can use? Because this genetic condition, gene therapy is only the definitive treatment which we can advise these patients. And next, the inherited acantholytic disorders, few points you need to remember. So Darius disease is also called as keratosis follicularis, and remember the other condition, Hailey-Hailey disease. So if you remember, we have seen these under acantholysis. And Hailey-Hailey disease is also called as chronic benign familial pemphigus. Both these conditions are autosomal dominantly inherited conditions where there is going to be a defect in the calcium ATPase, which is responsible for the normal functioning of a desmosome. So if there is a defect in this calcium ATPase, what will happen? The desmosome will not function normally, because of which there will be development of this acantholysis. So that is the reason why these are described as inherited, because these are genetic disorders, inherited acantholytic disorders. Acantholytic disorders. And what are the chromosome gene defects? These are also important, previously asked. So in the chromosome, remember, chromosome number 12 is associated with Darius disease, and it is ATP2A2 gene defect. Whereas in the case of Hailey-Hailey disease, it is ATP2C1 and chromosome number 3. Now let us discuss about the hair. So remember, hair loss is called as alopecia. Everyone is crazy about hair. I want hair. Hair is falling. I am preparing for exam and there is loss of hair. So what to do? So many messages I am going to get on Instagram, Telegram, that gram, this gram. Okay. So do not worry, guys. So what is the problem you are having? I will tell you in the next slides. So before that, remember, alopecia is the term which we use for hair loss. Okay, it can be two types. Okay, non-scarring, which is also non-cicatricial type of alopecia. scarring, which is also called as cicatricial type of hair loss, that is alopecia. And remember, cicatrix means scarring. So this cicatricial type of the scarring or alopecia is very, very bad. Once the hair is lost in this cicatricial type of alopecias, it is lost forever. Why? Because the stem cells which are present in the bulge area, they are going to be destroyed. So the hair will not regrow. Okay. So what are the important, findings which we can see in non-scarring and scarring? Very simple. So in scarring, the hair follicles will be destroyed forever and it is irreversible in nature. And also over the skin, we can see there may be some pustules, some scaling in the case of scarring or cicatricial types of alopecia. Now coming to the important examples, classification of non-scarring or non-cicatricial alopecia. Remember, non-scarring, non-cicatricial alopecias are the important diseases which you need to remember. If you can remember all these, you can, rule out the other options where the examiner might be asking you what is the cicatricial alopecia among the given options. Okay. So remember these names, very important. So depending upon the pattern, we have 4 important patterns. So patch, it could be patchy hair loss, it could be diffuse hair loss, it could be patterned hair loss, or it could be due to systemic causes. In the patchy, remember we have alopecia areata, we have this trichotillomania which is integrated with psychiatry, tinea capitis which is basically a fungal infection due to dermatophytes over the scalp, and secondary syphilis due to Treponema pallidum. And in the diffuse varieties, remember we have this term effluvium. Effluvium means shedding of the hair. And what are the 2 types of effluvium which you need to know? One is anagen and the another one is telogen. So remember, in anagen effluvium, what will happen? The anagen hair which has to go to catagen, then to telogen, the anagen hairs are going to be completely destroyed and damaged because of the chemotherapy and radiotherapy for a limited period. Okay, after which again the anagen hairs are going to regrow. Okay, this is what is called as anagen effluvium, and it is seen in the patients who are going to take the chemotherapy or radiotherapy because of the underlying malignancy. The hair will again regrow in these patients, not to worry. Now coming to the telogen effluvium, which most of the students who are preparing for the examinations might be suffering with. So because of the stress in the examinations, or there are other causes also. Because of the COVID, infections like typhoid, malaria, dengue, chikungunya, okay, or even pregnancy. Oh, some students might be also undergoing pregnancy while they are writing the examination. Okay, whatever may be this stress, because of the stress, what happens? The anagen hairs are going to convert it into telogen hairs. And I hope all of you know that the telogen hairs are going to stay only for a period of 3 months over the body. So after 3 months, there is going to be a lot of hair fall. This is what is called as telogen effluvium. So in the pattern, we have androgenetic alopecia. We are going to discuss this very important topic. And of course, in systemic causes, remember systemic lupus erythematosus and thyroid disorders, both hyper as well as hypothyroidism, can produce the hair loss. Right. Now coming to alopecia areata, very, very important topic, guys. Many times questions are asked. So this is basically A for alopecia areata. A for, this is an autoimmune condition where the antigen is again A, anagen hair bulb. And remember, areata itself means patchy or spotty areas of alopecia. So how the lesions clinically look like? The lesions are going to clinically look like circular areas of complete hair loss. Circular areas of, so as you are able to see here, these are circular or oval areas of complete hair loss will be seen. And what is the significant thing which you need to remember is there will not be any signs of inflammation, no pustule, no scaling, no itching, no nothing. Okay, skin, it will appear as if we took a blade or a scalpel and removed the hair. But one peculiar thing you can observe is in the lesions, we can see that the white hairs are still intact. The white hairs will be intact, or white hairs are spared. This is what is referred to as turning gray overnight phenomenon. Turning gray overnight phenomenon. Or this is also called as turning white overnight. So rhyming should be there, isn't it? Turning white overnight phenomenon. So why is this happening? Because remember, the autoimmune alopecia areata is going to damage the hair follicles which have melanin inside them. But the gray hairs do not have the melanin or melanocytes. So that is the reason why they are spared. So gray hairs will be left behind in this complete loss of hair. One more thing which you need to remember is the clinical appearance which is described as exclamation mark here. Very, very important term. The basic funda behind this is, if you observe the hair follicle, there are going to be lymphocytes present near the hair bulb, and they are going to damage and destroy the hair bulb, because of which the proximal portion of the hair follicle is going to be very, very undergrown and it will be tapered. Whereas the distal end, it was normal previously. Okay, when it was present initially, there was no alopecia areata activity, so the distal end is going to appear broad. So this is appearing like a exclamation mark. So that is the reason why this is described as exclamatory mark hair. And remember, the normal hair follicles, if you see, this is the normal hair follicles, how do they appear? The proximal portion will be broad and the distal portion will be thin. Okay, so exactly opposite is seen in the patients of alopecia areata. So this is called as exclamation mark hair, and this is the picture. This is the actual picture of the hair follicle, which is showing this proximal tapering and distal broad end. And on the histopathology, what we can see, I have already shown you, peribulbar lymphocytes will be present, and these lymphocytes, they are present, they are in a grouped fashion, and this is described as swarm of bees appearance. What is this? A collection of the bees near the honeybee is honeycomb is called as swarm of bees appearance. And important nail finding which you need to remember in alopecia areata is there will be pits. First, you should know that pits will be present, that the depressions will be seen over the nail plate, and these depressions are present in a superficial fashion, and they are present in a regular arrangement, and these are described as fine pits. And because they are going to be very, very geometric, as if someone has taken a scale and drawn the lines, and after which there are pits formed. So that is the reason why these are described as geometric pitting in alopecia areata. Very, very important. Now coming to the treatment is going to be with topical or most likely intralesional steroids. So ILS stands for intralesional steroids. So into the lesion, we are going to inject the steroid. What is that steroid which you prefer to give in these patients? Triamcinolone, usually triamcinolone. So you can see here, this is a patient of alopecia areata where there is ILS being given. And also remember, there are some other diseases in which we can give the steroids intralesionally. So for your purpose, remember scabies, which is special scabies, nodular scabies. We are going to directly inject the steroids into the lesion. So if the disease is very extensive, systemic steroids can also be prescribed to these patients. So now we are going to discuss the trichotillomania. Okay, tricho is hair, tillo is pulling, mania is madness. So hair pulling madness, so simply put, okay. So this is basically a psychiatric condition which is associated with obsessive compulsion, and the patients are going to pull their own hair. Okay, it's not that patients are going to come and pull your hair, then we call them as psychos. Okay, psychopaths, but they are going to pull their own hairs. So they are pulling out of one's own hair. Usually this is seen in females, and here we are going to see that this is again a patchy type of hair loss, but the hair loss is going to be in an incomplete fashion. Incomplete hair loss will be there. So this is one patch of trichotillomania. So in this, you are able to see that there are some areas where the hairs are absent, but there are some areas where hairs are also present. So remember, the variable lengths of hair follicles can be seen in these patches of trichotillomania. And because they are pulling it with force, there can be bleeding coming, peribulbar area, or perifollicular hemorrhages can be seen on biopsy. Okay. Now coming to very, very interesting and hot topic of dermatology, androgenetic alopecia. Man, many are having this problem. See, remember, androgenetic alopecia is not only going to affect the men, it can also affect the women also. So let us see what are the differences in the pattern of this androgenetic alopecia. So in the men, okay, remember, the male pattern is going to be having a peculiarity of the frontotemporal hairline recession. Very, very important. Frontotemporal hairline is going to recede backwards. So what is this? So basically this is the frontal and this is the temporal portion of the hair which will recede backwards, and there will be balding of the vertex which we can see. So to simply say, in the men who are having androgenetic alopecia, the use of shampoo will reduce and the use of face wash will increase. Okay, we can say that. And coming to the woman, we have these two patterns where you are able to see broadly that the frontotemporal hairline will be spared. Okay, it will not show a recession backwards. So you are able to see this hairline is intact. You are only able to see that the central portion and also the partition side are having this hair loss. Okay, this is males who are having androgenetic alopecia. So you are able to see temporal frontal hairline recession is present. So this is the Brahmi where you are able to see balding. And you are able to see in the woman, remember here the frontotemporal hairline will be intact. The only problem is there will be sparing of the frontotemporal portion is very, very important for you to remember. Apart from that, in the central portion there can be loss of hair which can be seen. Now coming to the treatment, you are able to see so many legends are having androgenetic alopecia and they are least bothered. So if you are having AGA, do not worry much. Success and failure do not depend upon androgenetic alopecia. Don't worry too much about this. But if the patients are asking for the treatment, okay, topical treatment and oral treatment, both of them are available. Topically, remember the drug which you are going to use is minoxidil, and in the woman it is 2%, and in the males it is 5%. Whereas the oral form, remember the treatment is going to be with finasteride. Basically, finasteride is going to inhibit the 5-alpha reductase type 2. This was also asked recently, type 2. Remember that. And thereby, what is this going to do is it will reduce the conversion of the testosterone to dihydrotestosterone. So basically, T to DHT, it requires the 5-alpha reductase. Okay, and this DHT is responsible for the androgenetic alopecia, increase in the androgenetic alopecia. So what we are doing with the help of finasteride, we are inhibiting this enzyme. So the conversion of testosterone to DHT will reduce, and thereby AGA will be reduced. AGA will be taken care of. That is that there will be hair regrowth. Okay, and you are able to see so many legends. The Indian Iron Man Amrish Puri is there, and other famous Hollywood actors are also there. So these are the minoxidil and the finasteride, and of late recently minoxidil in the oral form is also being used for the androgenetic alopecia, for your kind information. Okay, so do not take the medications without the dermatologist consultation. Okay, very, very careful because they are having various side effects. Next is scarring alopecia. Remember, scarring alopecia are also important. You need to remember few of the important ones which are being asked again and again. So papillosquamous disorder lichen planus is associated with scarring alopecia, where we call it as lichen planopilaris. So here these are the images of lichen planopilaris, where you are able to see the scalp is having violaceous hue, okay, or grey hue. And next is granulomatous disorder. Sarcoidosis is also associated because of the granulomas. It can produce the scarring type of alopecia. Connective tissue disorders, DLE, discoid lupus erythematosus, and of course SLE also. These two can also be associated with scarring alopecia, and this is a patient who is having discoid lupus erythematosus. Okay. Next, we have infections, tinea capitis, inflammatory variants, where favus and chorion are the ones which are associated with scarring alopecia. I hope you can understand what I have put here. So these patients of favus and chorion are effed up. Why? Because the hairs once lost are going to be lost forever, ever. So here you are able to see this is a patient of favus, and here this is a patient of chorion. And you might be wondering, sir, SLE, systemic lupus erythematosus, and tinea capitis, we have also seen these two under the table of non-scarring alopecia. Then why are we again seeing them? Please remember, these two are associated with both non-scarring as well as scarring types of alopecia. That is what is important. And in the tinea capitis, I have told you black dot and gray patch. So these are the ones which are associated with non-scarring alopecia. Okay, that is about the scarring alopecia types which you have seen in the previous slide. So the next type is very, very important. This was asked 2 times in the INSET in the form of options. Frontal fibrosing alopecia. This is also scarring, obviously fibrosing. What are the points which you need to remember about this is, so this is seen in the woman where we are going to see frontal band of alopecia. So you are able to see this frontal portion of the hair will recede backwards and there will be scarring here. And also one more finding which you need to remember is the patients are going to have madarosis. So what is this madarosis? Loss of eyebrow hairs is called as madarosis. So this combination, when you are able to see, think of frontal fibrosing alopecia, scarring alopecia. Next, we are going to see the sweat glands. Okay, what is the classification of the sweat glands? So we can broadly divide them into eccrine sweat glands and apocrine sweat glands. Very, very important. Off late MCQs are also being asked on these topics. Okay, you need to know important points, basics about these glands. So eccrine glands, the mode of secretion, I hope you might have read this in your physiology. It is merocrine secretion. What does merocrine secretion mean? Basically, the cells of the glands, they are going to only throw out the secretions through the help of exocytosis into the duct. But the cell will be absolutely normal, intact. Whereas coming to the apocrine glands, so the mode of secretion is apocrine. Apex will be cut and it will form the part of the secretion. So apex will be pinched off. Are you able to see? This is the apocrine gland. You are able to see that the apex is pinched off and it is forming the part of the secretion which will reach through the ducts, apocrine ducts. And yes, decapitation will occur in this of the cells. Now coming to the arrangement, where they are present, what are the sites, what are the functions? We need to know a few important points. Eccrine glands, remember, they are present over entire body and they are present in high concentrations over the palms and soles. That is the reason why during exams, we are going to get the hands and palms and soles with sweat. We are going to have so much of tension. Okay, nerve supply is cholinergic sympathetic. When we are in so much of stress, tension, our palms and soles are going to be extremely sweaty, wet. Okay, and these eccrine glands are going to open onto the skin directly without any association with the hair follicle. Now coming to apocrine glands, here we are having some important features. So all of them are going to start with A. That is one thing which you need to remember. Where they are present, axilla, areola. Axilla was asked in INSET exam. Okay, very, very important. Even in the groin. And apocrine glands are going to open along the hair follicle, and it is adrenergic sympathetic innervation coming to apocrine glands. Okay, now how can you remember the eccrine gland features which you have seen? So if you observe carefully, CDE, cholinergic, direct opening, and everywhere, entire body, it is present. CDE is a trick with the help of which you can remember eccrine glands. Now coming to apocrine glands, the A is not finished yet. It is androgen dependent, that is testosterone activity is needed, so it will become, these glands will become active only at the puberty. And these are also described as pheromones. Okay, and because these apocrine gland secretion, they are going to be acted upon by the bacteria and we are going to get the body odor. And these this is described as pheromones, and under the control of pheromones, and because of which the body odor will be there and sexual attraction will occur due to the apocrine gland secretions. Now coming to eccrine gland, it is for thermoregulation. Otherwise, in your casualty, the patients who are coming with sunstroke, heat stroke, they are due to the problem with the eccrine glands. Okay, thermoregulation. Now coming to the disorders which are due to obstruction of the eccrine and apocrine glands. Remember that the miliaria is used where there is blockage of these ducts. You should know that eccrine glands, if the eccrine ducts are blocked, we call it as simple miliaria. Again, miliaria are nothing but gonorrhea in Hindi. Okay, and these are of 3 types. Miliaria crystallina, if the blockage is at the level of the stratum corneum. They are called as miliaria rubra if the blockage of the duct is at the level of spinosum, and called as profunda if the blockage is at the level of dermoepidermal junction. Okay, these are miliaria crystallina, rubra, and profunda, CRP. Now coming to the apocrine glands. This is also miliaria, but remember this is called as apocrine miliaria. Apocrine miliaria, which is also called as, this name is very important, pox for this disease. Pox for this disease. And how does the normal eccrine gland miliaria present? I hope all of you know, the reddish erythematous papules will be present over the body, anywhere over the body. But apocrine glands, because they are present in the axilla, areola, and groin, so the lesions will be present in the axilla. Important site which you need to remember is in the axilla. And remember, usually the patients of apocrine miliaria or Fox Ford's disease are going to be females, and the lesions are described as itchy papules or pruritic papules. Itchy can be skin colored or slightly hyperpigmented, and the site will be, of course, wherever the area the apocrine glands are present. Treatment is going to be steroids and retinoids. This is the section where you are able to see the hair follicle throughout its length, and you are able to see that erector pili muscle, which is responsible for giving the goosebumps for us, that is going to divide the hair into upper segment and lower segment. So what is that which I want you to see in this picture is simple, that this is a sebaceous gland and this is the apocrine gland. So you are able to see that sebaceous gland and apocrine gland, they are going to open through the ducts along the hair follicle. So you all know that apocrine glands open along the hair follicles. Remember, sebaceous glands also open along the hair follicle. Okay, but you need to know there are some conditions which are having the sebaceous glands open directly onto the skin surface without any association of the hair follicles. These are called as ectopic sebaceous glands. So what are those conditions? What are the names? Very important. The one which you need to remember is Ford's spots. So you might be remembering Fox Ford's disease. That is a disease, Fox Ford's disease. Very bad term. Fox is there, disease is there. So you can remember, in Fox Ford's disease, the patients are going to have this problem of itching. Okay, because it is Fox, something bad. Okay, whereas here it is simple, Ford's spots. It is absolutely physiological, asymptomatic. How does it present? Because of the sebaceous secretions, it will appear yellow in color. So yellow micropapules can be seen over the upper lip, as you are able to see here, or it can be seen in the buccal mucosa also. So here this is a zoomed in image of the Ford's spots. And these ectopic sebaceous glands, if they are present over the breast, we call them as Montgomery tubercles. Remember, there are various names to this ectopic sebaceous glands. Do not be confused. Okay, so Montgomery tubercles are the ectopic sebaceous glands present over the breast. Next, we have over the eyelids also. Okay, remember, this is another term which you need to remember, which are meibomian glands. Okay, and finally, over the prepuce, we are going to call them as Tyson's glands. Very important. All these names are extremely important previous year questions which you need to remember. Now coming to the discussion of acne vulgaris. Very important topic. Of late it is being asked little bit in a depth also. So remember, it is a chronic inflammatory condition which is associated not only with sebaceous glands but also with hair follicles. So it is a pilosebaceous unit disorder where there is an organism associated which was previously called as Propionibacterium acnes, but now it is being called as Cutibacterium acnes. Oh my god, what an irony. The lesions which it will produce are very ugly, but the name of the organism is Cutie. Unfortunate. So remember, Cutibacterium acnes is not only associated with acne vulgaris, which is the most common form of acne, but also it is associated with acne fulminans. Okay, we'll see what is this acne fulminans. Okay, the acne vulgaris, the patients are going to have polymorphic lesions. What does polymorphic lesions mean? So remember the most important special lesions associated with acne vulgaris are comedones, which are also the specific special lesions which can be seen in acne vulgaris. Remember, there are 4 grades: 1, 2, 3, 4. So in the grade 1 acne, we are going to have these comedones, which can be open comedones or closed comedones. Open comedones are also called as blackheads. Closed comedones are also called as whiteheads. So here you are able to see these are the open comedones and this is one of the closed comedones. What is the treatment of this grade 1 acne? Remember, very important, topical retinoids. Topical retinoids are the treatment which are you going to use. Vitamin A analogs, so tretinoin and adapalene are the ones which are going to use. Remember, isotretinoin, it is oral medication. It is not a topical retinoid. So please remember this very important point, which is some students might go wrong. Some of them have answered it wrong also. So these are the adapalene and tretinoin creams. Grade 2 is going to be associated with papillar lesions, erythematous papillar lesions. Grade 3 is associated with pustular lesions. Pustules will be there. Grade 4 will be having nodules and cysts, and it might also heal with a very, very bad scarring. Coming to the drug of choice, remember for grade 4 nodular cystic acne, the drug of choice is isotretinoin, which is also called as 13-cis retinoic acid. This was asked in the recent FMG exam. Instead of isotretinoin, the 13-cis retinoic acid, 11-trans retinoic acid, these are other options, but remember isotretinoin is also called as 13-cis retinoic acid. Okay, and what is the indication? Nodular cystic acne, and also in conditions which are resistant to other antibiotics, okay, which are given in acne vulgaris. Most common side effect is the dryness of the lips, which is cheilitis, but the most dreaded complication is teratogenicity. So we'll see that in the next slide, but before that, remember TCD stands for total cumulative dose. Total cumulative dose of isotretinoin should not be more than 120 to 150 milligrams per kilogram body weight. Very, very important numerical. This was also previously asked. So what is the lab investigations which you should do? So fasting lipid profiles and liver function tests, because isotretinoin can damage and derange the liver function. So we should do this, and also we should observe if there is any increase in the triglycerides and also cholesterol levels. Liver function test should be done. Most severe adverse effect which you need to remember is DISH, diffuse idiopathic skeletal hyperostosis. But the most dangerous complication which we have to be very careful, especially in India. So in other countries there is one thing which is called as eye pledge, basically in which isotretinoin usage is taken care of and monitored very, very carefully to prevent the reproductive age group women using this isotretinoin left and right. But in India the problem is it's not there. Okay, so anyone can take this medication isotretinoin, but if unfortunately if they get pregnant and it is a category X teratogenic drug, so problems are going to occur. And period of drug stoppage prior to conception, very, very important. Remember this. If a woman is having acne, if she took the treatment with isotretinoin, the wash out period which we have to advise is 28 days, at least 1 month or better 3 months. So after a woman took the isotretinoin and the treatment is stopped, we have to advise them to use the couple to use the contraception measures at least for a period of 1 month or 3 months, after which only they can conceive and become pregnant. Okay, because isotretinoin can be present in the blood circulation for 1 month or 3 months also. And remember, topical steroids are never used in the acne. Never used in acne. Oral antibiotics and oral retinoids given. Okay, but the patient is still not responsive. What could be the cause? Remember, usually the examiner will give a history of middle-aged woman. Middle-aged woman, the diagnosis which you should think of is hormonal acne. Very, very important. This was actual, question which came 37-year-old middle-aged. Usually acne is a disorder of teenage, but if this middle age is given, you should always think of something wrong with the type of acne. Okay, so obese woman, hirsutism is there, and the lesions are not responding to antibiotics. And what is the next part? Not responding to isotretinoin also. So this is a case of hormonal acne where we have to investigate to rule out the causes of the hyperandrogenism. The examiner might also give you, so here you are able to see acne lesions are there, you are able to see that there is hirsutism present, and apart from this, insulin resistance, which is very very important for the development of hormonal acne, may also be given. Hirsutism, irregular menstrual cycles, acanthosis nigricans, which is also associated with insulin resistance, androgenetic alopecia. So these are all the other associations which may be given in the question body. And these are all the syndromes which are associated with acne. If you remember Hyran syndrome, hyperandrogenism, insulin resistance, acanthosis nigricans, you might have read this in your gynecology. So Saha syndrome, it is not Saho, it is Saha. Okay. So in Saha syndrome, what do we have? S for seborrhea, excessive sebum production, acne, hirsutism, and androgenetic alopecia. So this is Saha syndrome. And Sappho and Papa syndrome, I hope you might have read this in your orthopedics. Okay. So I have told you we will see acne fulminans in the later slides. So this is acne fulminans, which is also called as acne maligna, which is associated with Cutibacterium acnes. And this is going to clinically present in the form of the patient presenting with hemorrhagic and ulcerative nodules over the body, and there will be fever and arthralgia also. So this is a relatively serious condition, a subtype of acne, but this is again associated with Propionibacterium acnes. So what are the differential diagnoses with acne? Remember rosacea. We are going to discuss this in the next topic. Acne rosacea is our other term, but this is not associated with acne. This is a different condition, which is a chronic inflammatory facial dermatosis. So this is going to be confined to face, unlike acne vulgaris, where the lesions can be present over the trunk and also over the back. Okay. And what are the sites where the lesions will be seen? Centrofacial area, usually the convexities of the face, wherever there is high likelihood of sunlight exposure. So just imagine a person who is having some kind of a stress. So to reduce the stress, they are going for a party and they are having this spicy food along with the party, and where they are going? In the sunlight, broad day sunlight. So if a patient of rosacea has this combination, the lesions are going to worsen and increase even further, because these are all the triggers for the rosacea. And what is the basic problem in rosacea is there is abnormal vascular reactivity. Abnormal vascular reactivity is there in these patients. How does it manifest? The lesions can be erythematous and telangiectatic. That means erythema can be seen, which is called as flushing in normal terms, and there can be also dilated blood vessels, which we call as telangiectasia, which you are able to see here. Or the patients may also present with a combination of papules and pustules, which is papulopustular stage of rosacea. So you are able to see papules and pustules can be seen in these patients. There can be another presentation which is called as phymatous type of rosacea. Phymatous, it means there will be thickening of the skin. There will be thickening of the skin. If the thickening is present over the nose, then we call it as rhinophyma. And there is going to be also nodularity over the skin surface. And if you do a biopsy, what we can see? We can see hypertrophy of the sebaceous glands. Hypertrophy and fibrosis of the sebaceous glands can be seen. And what is the treatment which we can use? Carbon dioxide laser excision can be done as a treatment. And remember, this thickening of the skin, if it is present over the chin, we call it as gnathophyma. If it is present over the ears, we call it as otophyma. What is the treatment? Because it is an abnormal vascular reactivity, we can use alpha agonists like, for example, brimonidine and oxymetazoline. And topically, we can also use metronidazole and doxycycline in the systemic treatment. So these are all the treatment modalities which we can use for the patients of rosacea. So how can you differentiate acne and rosacea? Very simple. So in the acne, comedones are present. Very important. In rosacea, comedones are absent. In acne, the skin will be greasy, Whereas in rosacea, skin will be red, flushing, and there will be dilatation of blood vessels, telangiectasias. And acne, remember, not only face, trunk, chest also may be involved. And in rosacea, remember, it is a disorder of the face. Okay, other areas will not be having the lesions. Remember, rosacea is also differential diagnosis for SLE. Why? Because both of them can present with photosensitivity and also malar rash. Remember, photosensitivity can be present in both these conditions, and also malar rash, the erythema, can be seen in the rosacea, which might be confused with SLE. That is what is called as malar rash or butterfly rash. I hope you all know butterfly, butterfly. Okay, so triggers will be mentioned in the case of the rosacea. SLE does not have any triggers. Papules and pustules will be maybe seen in the rosacea. They are absent in SLE. Okay, and erythema is transient in nature initially in the case of the rosacea, whereas later on it will become fixed. Whereas in the case of SLE, it is a fixed erythema which will be seen over the face. Systemic features, obviously, systemic lupus erythematosus will have systemic features in the form of fever, arthralgia, and also oral ulceration, which will be absent in the rosacea. Now, let us discuss the nails. So, in the nails, remember, we have this leukonakia. Leuko is white, onychia is nail. So, white colored nails. If the white colored nails are because of the involvement of the nail matrix, we call it as true leukonakia. And the important example which you need to remember is measlines. Whereas if the leukonakia is due to the involvement of the nail bed, we call it as apparent leukonakia. Okay, what are the important examples? Muirke's bands, half and half, that is Lindsay nails and terrace nails. These are all the important examples for apparent leukonakia. First, let us discuss about the nail matrix problem, that is true leukonakia seen in arsenic poisoning. Very, very important. You might have read this from Gurudev Atul Gupta sir. The arsenic poisoning, it is going to show the measlines, which will appear as horizontal transverse white bands present over the nail plate. You are able to see horizontal transverse white bands. Coming to the apparent leukonakia, remember the Muirke's bands. Okay, Muirke's bands, it is going to present as paired transverse white bands. So here this term is important. The transverse white bands will be in a paired fashion. So this is 1, 2, 3. So like this, there will be so many transverse white bands present. And what is important association of Muirke's bands? It is hypoalbuminemia. Very, very important. Or even nephrotic syndrome and even malnutrition. So remember, it is hypoalbuminemia, which is important association with Muirke's bands. Next one is half and half nails, which are also called as Lindsay nails. And these nails are seen in the kidney failure. Remember, here the nail is going to appear half white, the proximal portion is going to appear white in color, the distal portion is going to appear brown in color. So because half nail is appearing white, half is appearing brown, it is called as half and half nails. And important association, kidney failure. How can you remember this? Just imagine the right and left kidneys, and this kidney is one half and this kidney is one half, like some kind of a relation. Okay, half and half nails, Lindsay nails. So how can you remember the Lindsay portion? Okay, simple. So I hope you all remember the famous movie which was having this dialogue of Bilkul risk nahi lene ka, risk nahi lene ka. Okay, so risk can be pronounced as a risk. So likewise, we are going to change the kidney into kinde. Okay, Lindsay nails, kinde. Okay, some form of incorporation is happening. Okay, this may sound stupid, but yeah, some or the other way to remember the Lindsay nails, half and half nails, kidney failure. Next is terrace nails. This is very simple. So in terrace nails, what happens is the proximal portion, almost 90% of the nail is going to appear white in color. Only 10% of the distal portion will be pink or brown in color. This is associated with liver diseases. How can you remember this? Liver, terrace, again, both of them are incorporated very nicely. So this is how you can remember all these nail changes with the help of different techniques. I hope you have enjoyed this video. Just continue watching the rest of the portion also, and remember to revise as soon as possible so that you can easily quickly revise whatever you have read. Okay, so in this video we are going to see the pigmentary disorders, papillosquamous disorders, eczema and histamine related disorders, and the genodermatosis. So first let us cover the disorders of hyperpigmentation. First, the most important condition, which is melasma. If it occurs in the pregnancy, we call it as cloasma. Remember this point. And how does it clinically present? It presents as symmetrical hyperpigmented brown macules. Where can we see that? We can see in this images, as you are able to see. Over the cheeks, we can see this malar area, nose, and also the mandibular area. So these are all these sites where we can see this brownish or even little bit dark black pigmentation, which is symmetrically arranged. This is very important. Why? Because in the recent FMG examination, there was one MCQ where it was mentioned that the cheeks were having the symmetrical brownish pigmentation, and some students thought it was suntan or some other DDs. But please remember, if you are given that there are patchy macules, macular or patchy type of pigmentation over the sun exposed areas, think of the diagnosis as melasma. Okay, and the differential diagnosis for this condition could be systemic lupus erythematosus, but you can easily differentiate both conditions. See, basically in SLE we are going to have a malar rash, that is a butterfly rash, and it is going to be red in color in the case of SLE. So that is how you can easily differentiate SLE from melasma. Okay, in melasma also over the malar area, that is over the cheek, we can see a rash, but this rash is going to be brown or black in color, but not red in color, which we can see in the SLE. So here you can see this is a beautiful image where this butterfly is seen. And what is the treatment? We can use the sunscreen because melasma is associated with ultraviolet radiation. And in the sunscreen, you can remember that we have the zinc oxide, and also the titanium dioxide. Basically, these are nothing but physical sunscreens. These are physical sunscreens. I hope you all know who are all these great players. They are wearing the physical sunscreen over their face. This was a very favorite question for AIMS INSCT. The question is going to mention fever and joint pain, after which there was a medication intake in the form of NSAIDs, and the patient observed the skin lesion, that is over the nose. You are able to see the melasma like pigmentation. So now what is the diagnosis for this condition? Please remember, this fever and joint pain is going to tell you that it is a case of chikungunya, and in chikungunya it was observed that melasma like pigmentation over the nose can develop, which is called as chick sign, very important MCQ which you need to remember. So history of joint pain, fever, pigmentation, think of chikungunya fever and chick sign, CHIKSIGN. It is not CHICK. It's not those chicks. Okay. So next we have the hyperpigmented lesion, which are freckles and lentigens. So remember, freckles, they are seen over the sun exposed areas, and remember the melanocyte activity will be increased in the freckles, whereas melanocyte number will be normal. And freckles, they are going to worsen during the summer season because there will be more and more ultraviolet radiation, so there will be worsening of the freckles. And how do they present? They do present as clinically as, if you observe carefully, these are the small freckles which you are able to see over the face in the form of hyperpigmented macules. I hope you know who this Hollywood actress is. She's Emma Watson from Harry Potter movie, right? And also there is one more condition which is associated with freckles. It is xeroderma pigmentosum. This was also asked recently in FMG exam, so you should know important points about these conditions. It is Autosomal recessively inherited condition, basically in which there will be nucleotide excision repair defect. We will discuss this in the miscellaneous topics, but remember freckles are seen in XP, xeroderma pigmentosum. Coming to lentigens, these can be same like freckles only, hyperpigmented macules, which can be present over the sun exposed areas and also sun protected sites. This is a very important point. And in this lentigens, remember the melanocyte number is increased. The melanocyte numbers are increased. And the important association which you need to remember is Peutz-Jeghers syndrome, in which we are going to see very important mucosal lentigens. We are going to see mucosal lentigens. And these are the lentigens which can be present over the sun protected areas of the body also. Right? And this is a picture just to help you to understand the difference between normal skin and the lentiginous skin if we take a biopsy. So in the normal skin, for example, there are 4 melanocytes. So this is just for example, if a given area is having 4 melanocytes, in freckles also there will be 4 melanocytes. Whereas in the case of lentigens, there will be many number of melanocyte. Melanocyte number is increased. Whereas in the freckles, what is the difference? The amount of the melanin which is produced is increased. Okay, that is how the freckles lentigens can be differentiated. Yes, this is Peutz-Jeghers syndrome. Just remember, this is important from surgical aspect also. So we can see the polyps in the jejunum, and these are basically hamartomatous polyps which can be seen in Peutz-Jeghers syndrome patients. Hamartomatous polyps. Now coming to next condition, CMN. This is also previous MCQ, congenital melanocytic nevus. Very important. So the name itself is telling it is congenital. So the lesions will be present from the birth. And the lesion, the lesion can be unilateral or it can be also bilateral. And there will be hyperpigmented lesion with well demarcated borders. So you can see very well demarcated borders, and of course hyperpigmentation is seen. On the surface, if you observe carefully, what is there? There is increased hair growth, which is called as hypertrichosis, that is increased hair. And site can be present anywhere over the body, but remember, if it is more than 20 centimeters in size, we call them as giant congenital melanocytic nevus, and the patients are going to be at increased risk of developing malignant melanoma. MM is melanoma, which is of course malignant. So this was the previous year question. You need to know about this. The next condition is called as Becker's nevus. Becker's nevus, remember, this is an acquired condition. So wherever you see nevus, remember it is a birthmark. Okay. But unfortunately, Becker's nevus is not going to be seen since birth. It is an acquired condition which will be seen during puberty, and it is a unilateral condition. So it will be only present on one side, and of course, it is going to be hyperpigmented. That is why we are reading in pigmented disorders. And also, surface will be having increased hair growth. And the lesions can be present over the chest and upper shoulder, most likely. So now you might be getting doubt. How to differentiate between CMN and Becker's nevus? Simple. CMN is congenital. So lesion will be seen from birth. Whereas Becker's nevus, it is going to be seen from the puberty. That is one thing. And other things are CMN, the lesion will be black, and here it will be brown in Becker's nevus. And of course, the CMN, the skin, if you touch, the skin will be very thick in congenital melanocytic nevus. It is normal in Becker's nevus, and the skin will be thrown into folds at few areas in CMN. Whereas the skin will be absolutely normal in Becker's nevus. And one more very important difference is that this can be bilateral also. Whereas Becker's nevus, it is going to be unilateral all the times. So the next concept is from the physics, very old. When dinosaur used to be present over the earth, we have read in physics. Okay, one concept called as Tyndall effect. So what is this? Simple. Let me tell you, whenever you throw light on the skin, okay, depending upon where the melanin is present, depending on that, the color of the skin will be different. For example, if the melanin pigment is present very superficially, stratum corneum, skin will be black in color. But if the melanin pigment is present very, very deep in the dermis, then the color which you are going to see is blue color. Okay, so this is due to the partial scattering of the wavelengths. Okay, and the most important color is blue color, which you need to remember. We are going to discuss the dermal melanocytosis. So proliferation of the melanocytes, if it occurs in the dermis, we get a blue color, and this is described as ceruloderma. You all know about the cerulo term. I hope that you know whenever you see anything blue in color, we describe it as cerulo. Remember macula caerulea, which we can see in thymus pubis? Yes. Likewise, here also blue colored skin is going to be seen. So it is described as ceruloderma, blue skin. And the important names of the diseases which you need to remember are, one is Mongolian spot and the other two are nevus of Ota and nevus of Ito. So let me quickly tell you what are the important points related to these three important conditions. So Mongolian spots seen in infants, and how does it appear? Blue slate gray colored skin will be seen over the lumbosacral area. And one good news, it resolves spontaneously. Okay, this is the dermal melanocytosis which will resolve spontaneously, whereas the rest of the two are very, very difficult to even treat. So what is the next condition? Nevus of Ota. Remember, this is going to be unilateral on right or left, any one side. And of course, the color will be, this is dermal melanocytosis, so blue or slate gray in color. And this is going to follow the first and second divisions of the trigeminal nerve. And yes, they are ophthalmic and maxillary divisions. Obviously, it will be involving the face. It will involve the face. And remember, simple trick, nevus of Ota. Okay. So over ophthalmology. So remember, the patients, 2/3 of the patients can have the sclera, which is blue in color. Scleral involvement can be there. And one more interesting thing, this nevus of Ota is a unilateral condition, whereas there is one condition called as nevus of Hori, in which we can see the bilateral nevus of Ota. And in this beautiful image, you are able to see sclera is blue in color. And of course, the skin over the face is also blue in color. Next condition is nevus of Ito. So same features like nevus of Ota, but the only difference is the site is going to be now different. Just remember that the site is going to be upper shoulder and also over the back. So how can I remember this nevus of Ito as upper shoulder and the back? Simple. In Hindi, remember, eat means bricks. So these are the bricks. Okay. So who is this character? I hope all of you know. This is Bahubali. And what is Bahubali carrying? Hara Hara Mahadev. Okay. So now, instead of the Bahubali carrying the Hara Hara Mahadev, we are going to place some bricks for us to carry uphill. Okay. Eat are nothing but the bricks. So with the help of that, you can remember the nevus of Ito, the site of nevus of Ito as the upper shoulder and the back. So how can you differentiate between Becker's nevus and nevus of Ito? Very simple. Becker's nevus, it is associated with increased hair growth, hypertrichosis. That is not present in the nevus of Ito, whereas the color in Becker's nevus, it is brown in color. Very important. It is brown in color, and here it is blue patch. And one more important, interesting difference, nevus of Ito. It is a nevus, so seen from birth, and Becker's nevus is seen during puberty. These are all the differences. So this is the image. So in the image, you may see, you may think that both are looking same, but remember the differences which I have already told you in the last slide. And there is one more easy way to remember Becker's nevus. So just imagine when you are going to any saloon. Ultimately, some or the other time we may experience this, that the most waste person is sitting idle and ready to cut our hair. So they are called as waste persons. They are called as bekar in Hindi. So remember the bekar barber. That is the person who is going to be there for you to cut your hair. So just imagine that with the help of that you can remember that Becker's nevus is associated with the hair. Baker is waist person, waist barber. Okay. And in the treatment of the dermal melanocytosis, OTA or ITO, we are going to use a laser which is called as Nd:YAG laser. Nd:YAG laser is used for the treatment of OTA or ITO. And this is one more previous, a question which is asked in the May 2024. So which of the following drugs which is used in leprosy treatment can cause hyperpigmentation? Very, very important, students. So the answer for this question is clofazimine. Clofazimine, the usage of clofazimine is associated with increased chances of pigmentation of the skin. Remember, it is going to be clofazimine, which is basically actually a dye, because of which it can produce a reversible pigmentation. Once the medication is stopped, there is going to be normalization of the skin color after few months to years. Yes, it takes time, but it is reversible. And some drugs which you need to remember which can be associated with pigmentation of the skin. You can remember those drugs with the help of this MCAB. What is MCAB? So MCAB is one, like Uber and Ola, it is one cab service. So M stands for minocycline. Minocycline can produce bluish pigmentation of the acne scars. C stands for, of course, clofazimine. A stands for amiodarone. It can produce blue discoloration. And B stands for very, very important name, bleomycin. It can produce flagellate pigmentation. Flagellate pigmentation. Okay. So next we are going to look at the disorders which can be associated with hypo or depigmentation. They can be congenital or acquired. So in the congenital, just remember this very important name, albinism. So basically what is albinism? Here the melanocyte will be absolutely normal. The problem is with the tyrosinase. I hope you remember from basics topic that tyrosin is the precursor molecule for melanin. So the enzyme which is important for the melanin production is tyrosinase. So in the albinism, this is defective. Melanocyte is absolutely normal. Melanosomes are absolutely normal. Everything is nice. But the enzyme is defective. Because of which what happens? The skin can be white or depigmented in color, or even the eyes can be depigmented. So if the eyes are only affected, we call it as ocular albinism. If the skin and also the eyes are affected, then we call it as oculocutaneous albinism. So here you are able to see hair can be completely white, depigmented, or skin and also the eyes can also be affected. So next is Chediak-Higashi syndrome. This is a syndrome, so it will have some combination of signs and symptoms. So what are the things which we can see in these patients? So there will be a gene defect which is List gene defect, and it is an autosomal recessively inherited condition. There will be defect in the phagolysosome function. So what will be the clinical features in Chediak-Higashi syndrome? So there can be peripheral smear which shows giant granules in the neutrophils. So the neutrophils are not functioning normally. So there can be recurrent infections in these patients. Platelets are also not functioning normally. So there can be bruising. And in the skin and eye, remember, patients may present with albinism. So these are all the important findings in the case of Chediak-Higashi syndrome. Okay. So here you can see these are the giant granules which can be seen in the neutrophils. Next condition is piebaldism. So piebaldism, basically the most important buzzword which you need to remember about this is white forelock. But before that, few important points. It is an autosomal dominantly inherited condition where the basic problem is in the from address of the melanocytes. What is the from address? It is neural crest. So the function of the neural crest is defective, because of which in few areas the skin is going to be not having the pigmentation. Most important side which you need to remember in piebaldism is the forelock area. What is forelock? See, I hope all of you know what are these. These are side locks. Bunch of the hair which is present on the sides is called as a side lock. So if the bunch of the hair which is present over the forehead, so this is the bunch of the hair which is present over the forehead. If this is depigmented, then we call it as white forelock. And also remember, over the forehead, there can be depigmented patch present. So this two, when combined together, we call it as white forelock, and it is a characteristic lesion for piebaldism. So not only the involvement of the face, but also other body areas also can show this depigmentation. Okay, so like for example, this child, yes, of course, the white forelock is present in this child, but apart from this, what you are able to see is there are depigmented areas present over the trunk and also over the extremities. And you are able to see some islands of the normal skin in this child. So let me give you a perspective. So if the examiner gives you only the image of the abdomen and the extremities having depigmented lesions, then the diagnosis will be vitiligo. So I will show you how vitiligo presents. Yes, this two, if they are present, only if these two are present, diagnosis is vitiligo. But if along with the body involvement, even face involvement is given in the case or in the picture, then the diagnosis is now going to be piebaldism. So differentiating these two can be done with the help of the facial lesion, white forelock. So that is the reason why it is very, very important for the diagnosis of piebaldism. Remember this point. And here you can see, you can remember the mother is also having this lesion. So it is autosomal dominantly inherited condition. So next condition is nevus depigmentosa. So it is a birthmark. So don't think that birthmarks are always black in color. White birthmarks are also seen. So one of the examples is nevus depigmentosa, which is also called as nevus acromicus. So basically what happens is that there will be a defect in the transfer of the melanosomes to the keratinocytes. We have discussed it in the epidermal melanin unit, isn't it? So melanocyte, with the help of dendritic processes, it will donate the melanosomes and the melanin to the adjacent keratinocytes. Here there will be a problem, a defect in that transfer, because of which there is going to be from the birth a depigmented lesion which can be present over the body, and it is going to have feathery margins. So this is nevus depigmentosis. There is one more condition in which the presentation can be exactly same like depigmentosis, but the difference is going to be present beneath the skin. What is the difference? So remember, nevus anemicus is a condition which is due to the vasoconstriction, where the skin is going to appear pale in color. So if you remember, in anemia, we call it as pallor, isn't it? So why? Because the person is going to appear very pale, because there is no RBC, there is no hemoglobin in these individuals. Okay, likewise, similar to that, in this condition, there is vasoconstriction. Okay, relative reduction of the blood is seen in these patients. So because of which skin will appear as if it is white in color since the birth. Okay, so that is the reason why this condition is not a melanin disorder per se, but it is a pharmacological disorder where there is blood vessel excessive vasoconstriction. Okay, and because of the reduced blood supply, skin will appear white in color. Next, we have the acquired disorders of hypo and depigmentation, in which the most important condition you need to know is vitiligo. Right? So remember, vitiligo is an autoimmune condition in which there is damage or destruction of the melanocytes by the patient's own immunity. Unfortunate, isn't it? Yes. And so you all should also remember that wherever there is some kind of autoimmunity, there is another autoimmune disorder also a possibility in that individual. So always try to evaluate those persons. For example, there can be underlying thyroid dysfunction, hypothyroidism may be there, type 1 diabetes or pernicious anemia. Any of these autoimmune conditions may be there. And clinically, how do the patients of vitiligo present? Depigmented chalky white macules can be present, and if you take a biopsy and see if the melanocytes are present or not, remember, melanocytes will be absent in the skin lesion of vitiligo because they are damaged and destroyed by the immunity. The classification is very important. Many questions are asked based on the classification. So based upon whether it is in a segmental fashion, we have segmental vitiligo if it is not arranged in segmental, non-segmental, and also unclassified, undeterminate variety of vitiligo. So in the segmental vitiligo, some important points to remember. This is going to start in the early childhood. And one more point, the segmental vitiligo, yes, as the name suggests, it is going to follow the segments, usually the dermatome. So this is going to be unilateral. Only on one side we can see the vitiligo patches. Okay, and it does not cross the midline. Very important point, does not cross the midline. And one more important point which was asked in the recent ANA, it initially is going to be progressive and later becomes stable and non-progressive. Very simple to understand, man. Segmental vitiligo. So for example, if the vitiligo patch was starting here, okay, so it will progress like this over a period of let's say 1 year. So it will reach the end of the dermatome, and ultimately what will happen? The dermatome is completely involved, so there cannot be any more progression. So it is going to become stable and non-progressive. This is a simple concept behind the segmental vitiligo. I hope you have understood this. In the treatment, remember, usually vitiligo is treated with medical treatments, but segmental vitiligo starts with yes, so it needs surgical treatment modalities. So segmental, yes, surgical intervention. What is a surgical intervention? We can do a transplantation of the melanocytes. Very interesting, isn't it? Yes, from one area we can transfer the melanocytes and graft the skin. Okay, these are the surgical modalities which we can use for the segmental vitiligo. These are all some of the images, okay, in which segmental vitiligo is seen. Very important to just observe that, see, basically segmental vitiligo, it is usually going to follow the dermatomes, okay. But in some cases, it was observed that even Blaschko's lines also were followed by the segmental vitiligo. So that is the reason why you are able to see these two images. So on this side, you are able to see that it is dermatomal, and on this side it is Blaschkoid pattern. And here you are able to see one more image where the midline demarcation is very clearly seen, and you are able to see that this particular dermatome is affected by the vitiligo. See, there can be discontinuity in the patch. It is not that the entire lesion is going to be the white in color. So there can be some discontinuity in these patches. Please remember that. So now coming to non-segmental vitiligo. Non-segmental vitiligo, please remember, we have acrofacial vitiligo. The name itself is self-explanatory, man. Acrofacial. So face and head, both are going to be affected. Mucosal vitiligo, in which mucosa will be having depigmented lesions. Vitiligo vulgaris, most common type. So most common type of vitiligo where symmetrically distributed depigmented macular lesions can be present. This point is important. Symmetrically distributed lesions will be present over the body. I will show you the images. Next is universal vitiligo. Universal vitiligo, you might be knowing, Michael Jackson had this universal vitiligo. Okay, so 80 to 90% of the body is going to be depigmented. Unclassified variety, which is also called as undetermined type of vitiligo. So here the problem is that patients might be having some 1 or 2 depigmented patches over the body here and there. So it is it's a condition where patients are going to be very, very cautious, and they are going to ask us, doctor, is it going to involve, is it going to become generalized and involve entire body? So we don't know what it will progress to. So we have to tell the patients to monitor the lesions. Okay, that's what we can do. So this is the image of acrofacial vitiligo. Acrofacial. So in the extremities, depigmented lesions, and over the face, depigmented lesions can be present. Next is vitiligo vulgaris. It is the most common type. Yes, symmetrically distributed depigmented lesions can be present all over the body. So you can see here the areas, few areas of normal pigmentation are remaining. Rest of the other areas are appearing depigmented, and the distribution is symmetrical. And this is mucosal vitiligo where mucosa will become depigmented. And I hope you all might be knowing this is Michael Jackson. Michael Jackson, king of pop, god of music, actually had universal vitiligo. So initially his skin color was very dark, but because he developed the vitiligo, so ultimately his skin color became very, very white. So almost 80-90% is affected. So remember some important findings in the case of vitiligo. So one is Koebner's phenomenon. Koebner's phenomenon. So true Koebner's phenomenon is going to be positive in the patients of the vitiligo. So what is this Koebner's phenomenon? Please remember, the new lesions are going to appear at the site of the trauma. New lesions are going to appear at the site of the trauma. This is what is referred to as true Koebner's phenomenon. For example, if a patient is having vitiligo lesion over the left hand, okay, and then if the patient, by mistake scratches the skin, then what will happen? Over the traumatized skin, there is going to be development of the vitiligo lesions, that is depigmented lesions will be developed in a linear fashion along the lines of the trauma. This is what is referred to as Koebner's phenomenon, true Koebner's phenomenon, because the underlying pathology is autoimmunity. And remember, the Koebner's phenomenon, isomorphic phenomenon, can also be seen in other conditions. All those conditions you can remember with the help of PSLV. PS is psoriasis, lichen planus, and vitiligo. Psoriasis, lichen planus, and vitiligo. Okay. And also leukotrichia can be observed. What is leukotrichia? Hair follicle melanocytes, if they are damaged, then the hair, that is trachea, will become white in color, which is called as leukotrichia. So here you are able to see the images which are depicting the KP, which is Koebner's phenomenon, where there is some trauma due to the belt and there is depigmented lesion developing over the area wherever there is some trauma. And here you are able to see there is a linear depigmented lesion, vitiligo lesion. This is also Koebner's phenomenon. And you are able to see in this image the leukotrichia, that is white colored hair because of the destruction of the melanocytes in the hair follicles. Here you are able to see that skin is also depigmented. And of course, Woodslam finding, we have already seen milky white fluorescence can be noted in the patients of vitiligo. And treatment is going to depend upon how much body surface area is affected. So if it is less than 20% of body surface area, we can take care of the vitiligo with the topical steroids. Okay, but if the involvement is more than 20%, it is difficult for the patient to apply the cream everywhere over the body. Then we are going to use systemic steroids or other steroid sparing agents, like for example azathioprine, or if we can also use phototherapy in the form of NB-UVB. There is one more problem, if there are certain chemicals which come in contact with the skin, which can damage and destroy the melanocytes, we can also see white colored skin in those conditions, in those chemical contacts. So these are called as leukoderma, and chemical leukoderma is the name which you need to remember. Because of the chemicals, there is whitish discoloration of the skin. Chemical leukoderma. And what are those chemicals? Remember, this is also very important. So in bindi, there is going to be PTBP, which is para-tertiary butylphenol, which can damage and destroy the melanocytes. Because of which there will be whitish discoloration wherever the chemical is coming in contact. And there is, rubbers, slippers, which can have MBEH, monobenzyl ether of hydroquinone, which is again going to damage the melanocytes, leading to depigmentation wherever the material is touching the skin. And same like that, alta is a dye which is worn by the woman during the marriages, which consists of crocin, scarlet mauve, and solvent LO3, because of which there can be chemical leukoderma. Okay. So next we are going to discuss the papillosquamous disorders, in which the most important one, psoriasis. Of course, the others are also important, lichen planus, pityriasis rosea, pityriasis rubra, pilaris. We are going to discuss all these things. So coming to psoriasis, remember, by definition, it is a T-cell mediated, chronic T-cell mediated inflammatory process in which not only skin, but remember, multiple other systems can also be affected. Like for example, it can also affect joints. You might also read this from Dr. Apur Mehra sir, in the form of psoriatic arthritis and its manifestations. Not only that, remember, this can also come in the medicine also. Why? Because psoriasis is also associated with metabolic syndrome. Very, very important for you to remember. But in the dermatology, how does it manifest? Yes, in the form of red blobs which have a silvery white scaling. So you might be knowing this famous Hollywood actress. If you know, you know. Okay, Kim Kardashian, she also has the psoriasis. she also has a psoriasis. Okay, so there are various factors which can be associated with psoriasis. So in the season, remember, this condition, psoriasis, is going to be exacerbated during the winter season, and there are certain infections which can also aggravate this psoriasis or produce some special type of psoriasis. One of the special type of psoriasis which you need to remember, very important, is guttate psoriasis. Guttate psoriasis. Few points about guttate psoriasis. So this is commonly seen in the children. And what is the infection which is going to be associated to this guttate psoriasis? It is the sore throat, that is pharyngitis with GABHS. What is GABHS? Group A beta hemolytic streptococcus. Where the patients are going to be children, they are going to be presenting with scaly erythematous lesions over the body in a pattern which is called as raindrop like pattern. Very important, remember gutta, wherever you hear this word gutta, remember it is associated with raindrop like pigment, not pigmentation, raindrop like appearance. So here you are able to see these are the red scaly lesions which are present over the trunk. The lesions are importantly present over the trunk. And remember, in the psoriasis, we make use of so many medications, like for example, methotrexate, acitretin, cyclosporin. But in guttate psoriasis, because it is associated with infections, the treatment is going to be with antibiotics, macrolides. Very, very important and interesting type of psoriasis. Okay. Coming to the drugs, remember the mnemonic for the drugs which are associated with the psoriasis is PLAB. Yes. So what is P? Painkillers. What is L? It is lithium. What is A? It is anti-malarials. B is beta blockers. Yes is very interesting. Okay, remember all these medications, if they are given to a patient who is having predisposition to develop psoriasis, they can aggravate or trigger the psoriasis. Whereas yes is systemic steroids. Please remember the systemic steroid withdrawal. Withdrawal in a patient of psoriasis can aggravate the psoriasis and produce more dreaded complications of psoriasis, which are pustular psoriasis and erythrodermic psoriasis. We are going to discuss this in the coming slides. Okay. Coming to substance abuse. In the substance abuse, remember alcohol and smoking are going to aggravate the psoriasis. The pathogenesis, basically in the dermis, there is going to be a lot of inflammation happening. Because of this inflammation, there is going to be the dermis which will be hyper proliferated. Okay, this simple thing. Remember, in the dermis there is inflammation, and in the epidermis there is going to be hyper proliferation of the keratinocytes. But I hope you all do remember this concept of transit time, which is reduced by 10 times. So 4 to 7 or 3 to 5 days is going to be the time now. And there are various, cellular components and the signaling cytokines which you need to remember associated with psoriasis. So simply remember T helper 1, 17 and 22 by the help of the production of the interleukin 2, 17, 22 you can remember. Okay, TNF alpha, interferon gamma. All these are pro-inflammatory cytokines. So they are going to increase the inflammation in the dermis. And now coming to the clinical types of psoriasis. So we have discussed guttate psoriasis. Please remember the most important type of psoriasis is also called as psoriasis vulgaris. Of course, you know that it is also called as chronic plaque psoriasis. This other name is also important for you to remember because it was asked once in an FMG examination. So chronic plaque psoriasis is also called as psoriasis vulgaris. It is the most common type which is going to present clinically as erythematous plaques which are surmounted by silvery white scales. Yes, erythematous scaly papules and plaques, micaceous silvery white scale will be present on the surface. And what is the site? Very important. Site is going to be extensors. Site extensors, that is elbows, knees, over the lumbosacral area. All these areas can be having the psoriatic lesions. Remember, if the psoriatic lesions are present in the flexures, we call it as inverse psoriasis. So flexors do not have the lesions of psoriasis usually, but if they are having, we call it as inverse psoriasis. Normal is extensor, opposite is inverse. So here you are able to see the inframammary area, you are able to see in the axilla, you are able to see in the elbows. So antecubital fossa. So all these are flexures. Okay, inverse psoriasis. Next we have pustular psoriasis. Pustular psoriasis, very interesting and important topic for AIMS exam. Please remember this. So patients of psoriasis, if they are by treated by some chola chap or the quacks, we call in English quacks, they are going to prescribe the oral steroids. My God, systemic steroids, because of which initially the inflammation will reduce in the patients of psoriasis. But once the steroid is stopped, then hell will be broke and the patients are going to develop extensive pustules all over the body, and these pustules are having some characteristics. They are absolutely sterile pustules, so they are not going to have any bacteria or any infectious material, but they are going to cause a lot of problem. Why? Because they are going to be present as sheets or lakes of pus involving almost the entire body. And yes, the trigger is sudden withdrawal of systemic steroids. So these are the images. Very dangerous condition. If a person comes with this, we have to admit the patient and we have to immediately treat the patient, diagnose it and treat it. Okay, so you are able to see pustules, sheets or lakes of pus are present all over the body. These are some of the other pictures where you are able to see the pustules. So the classification is based upon the extent. Okay, if it is localized to few areas, we call it a localized pustular psoriasis. But if it is generalized in normal individuals, we are going to call it as von Zumbusch type of pustular psoriasis. But if a pregnant woman develops the generalized pustular psoriasis, now we are going to use a different name. We are going to call it as impetigo herpetiformis. Please remember, this is a double misnomer. This is neither a impetigo, that is, it is not a bacterial infection, nor it is a herpetiformis, nor it is a due to herpes virus. But still remember this name, impetigo herpetiformis. It is generalized pustular psoriasis which occurs in pregnancy. Very important. And this is how pregnant women can have the pustular psoriasis all over the body. So next type of psoriasis, which can also be due to the sudden withdrawal of the steroids, is erythrodermic psoriasis. The name itself is self-explanatory, ma'am. So erythro, red, derma, skin in the patients of psoriasis is going to become red, erythematous. And also you should know other name of this. It is also called as exfoliative dermatitis. What is exfoliation? Exfoliation is scaling. Okay, so if there is redness of the skin and also if there is associated scaling involving almost more than 90% of the body surface area, we call it as erythrodermic type of psoriasis. And there can be multiple causes of erythroderma, please remember, but one of the causes is psoriasis. Okay, so here again you are able to see that there is a redness of the skin, and in the background of the redness you are also able to see that there are some scaling, exfoliation of the skin, exfoliative dermatitis. Next is the involvement of the joints. Please remember, this is a rheumatoid factor negative type of arthritis, and it is going to damage the joint. It is erosive arthritis. Classical joint which is affected is DIP, distal interphalangeal joint. And if there is inflammation of the digits, this inflammation of the digits, it is called as dactylitis. It is called as dactylitis. So there are some special signs or phenomenon which you need to remember in psoriasis. The most important one is Auspitz sign. So what is Auspitz sign? If there is a person who is having the scaly blocks, we have to take the glass slide, we have to remove the scales, and once we scrape the scales, okay, which is called as grattage. Finally, what we are going to see is, we are going to see one membrane which is called as Bulkley's membrane. And if you remove that, Bulkley's membrane is a white membrane. If you remove that membrane further, then finally we are going to see the end point, which is the pinpoint bleeding spots. So this is the patient who is having this scaly lesion, and we take a glass slide and start scraping of the scales, grattage. Finally, we will get to see Bulkley's membrane, not Berkeley's membrane. Okay, it is Bulkley membrane. Finally, we are going to see this small, tiny pinpoint bleeding spots. This is called as Auspitz sign, and it is the end point. Okay, pinpoint bleeding spots observation is the end point for Auspitz sign demonstration. So this is taken from the National Psoriasis Foundation And you are able to see that in this it is mentioned that she whenever feels little bit of itching over the skin and she scratches over the skin, usually psoriasis is not associated with itching, okay, but if the patient scratches, okay, then what happens is there can be bleeding. Okay, it is also mentioned here. So this bleeding is nothing but actually the auspit sign which she has actually performed. Okay, so next is Kobner's phenomenon. I hope you already know this. This is also called as, remember, isomorphic response. So what is isomorphic response? Iso is similar. Morphic is looking, morphology, looking lesions. Okay, similar looking lesions can develop. So this is a person who is having the psoriatic lesions. Okay, small erythematous scaly papules. And when there is a history of a trauma over the normal skin, because of the underlying autoimmunity, the lines of the trauma, along the lines of the trauma over normal skin, there will be development of the similar looking lesions. So whatever it is, for example, here it is psoriasis. Okay, so psoriasis like lesions will develop over the traumatized areas. Lichen planus can also develop, and vitiligo can also develop. I hope all of you do remember this PSLV. Polar Satellite Launching Vehicle is the actual term, but we are now using it for psoriasis, lichen planus, and vitiligo. Right? And what is the importance of these Kobner's phenomenon is whenever a patient is having Kobner's positivity, that means the disease is very active, and we should advise the patient to avoid any unnecessary trauma over the body, because over the traumatized areas, again, the lesions can be produced. And so we have seen what are the true types of Kobner's phenomenon: psoriasis, lichen planus, and vitiligo. So there are some pseudo conditions also which you need to remember. Due to the auto inoculation of the viral particles, there is going to be development of similar looking lesions over the adjacent normal skin. This is called a pseudo Kobner's phenomenon. And what are the examples? Viral infections, warts, and molluscum contagiosum are very, very important for you to remember. And there are certain rare causes for the development of the Kobner's. So among which, remember, the most important disease is lichen nitidus. Lichen nitidus. Warnoff ring is a term. Just remember, in the patients of psoriasis, it was observed that the perilesional skin is appearing hypopigmented, and this is basically due to the prostaglandins. There is some kind of imbalance in the PGs in the surrounding skin, lesional skin. That is the reason why there is this hypopigmented rim in the psoriasis lesion, which are called as Warnoff ring. So this is my beautiful thumb, which you are able to see. Beautiful, isn't it? So this is the nail plate, and this is the half moon shaped lunula. So just remember that in the psoriasis, one important nail change can be seen in the patients of psoriasis. What is that important nail change? So if there is a problem in the matrix, we are going to see pitting, which is the most common nail finding in the psoriasis. And apart from this, there can be also whitish discoloration of the nails, which is called as leukonychia. And of course, we have seen other causes for leukonychia. If you remember, Mees lines, Muircase bands, half and half nails, and Terry's nails. Okay, this is one more cause for white discolored nails. In the nail bed, what we can see the oil drop sign, which is also called as Salmon patch, onycholysis, subungual hyperkeratosis, and splinter hemorrhages. So let us look at one by one how the manifestations will be. So pitting of the nails, very, very important. Three important characteristics of the pits or the depressions which we can see in the nail plate. You can remember them as DIC. So it is not disseminated intravascular coagulation. Here it is, the pits are going to be deep and they are irregular in arrangement and they are coarse in nature. Exactly opposite to that of what we have seen in alopecia areata, if you remember. And the defect here is going to be, as we have already told, it is in the proximal nail matrix. So these are the small pits which you are able to see, which are very, very deep in nature and they are irregular. In arrangement and they are described as coarse pits. So this is yet another image where you are able to see the DIC, deep irregular coarse pitting. So this is the table which is showing the alopecia areata, where we are going to see exactly opposite, superficial, regular and fine geometric pitting opposite to nail psoriasis. The next finding in the nail psoriasis is onycholysis. But before that, you must know one more term which is called as subungual hyperkeratosis. So here basically the defect is going to be in the nail bed, not in the nail matrix. So here, skin of the psoriatic patients is going to be having the scaly plaques. Likewise, even in the subungual area, there is going to be proliferation of the nail bed, because of which we are going to see one whitish material which is present below the nail plate. This is what is called as subungual hyperkeratosis. And because of this subungual hyperkeratosis, what is going to happen is there is going to be nail plate separation from the nail bed. That is described as onycholysis. So nail lysis separation, onycholysis. And also you can see the nails can be thick and yellow in color in the psoriasis. And you can easily understand the concept of this onycholysis with the help of this real life example. So consider the car to be the nail plate, okay, and the road to be nail bed. Okay, car is nail plate, road is nail bed. So this subungual hyperkeratosis acts as a jockey and it will lift the nail plate from the underlying nail bed, which is called as onycholysis. I hope everyone has clearly understood what is this concept. Now we are going to see the important pathognomonic finding. Pathognomonic finding of nail psoriasis, which is also called as salmon patch, or it is called as oil drops. Simple. The nail below the nail plate, if we observe, we can see that as if some oil drop is present. That is how the lesion is going to appear as in this condition. And yes, yellow discoloration of the nail bed can be seen in this condition. So these are all the findings which can be removed with the help of this mnemonic. Okay, nail polish. So P for pitting of the nails, and remember this I stands for irregular pitting of the nails in psoriasis. O stands for oil drop sign and also onycholysis. L stands for leukonychia. S stands for splinter hemorrhages and also subungual hyperkeratosis. Okay, so these are all the findings which you can remember. In the scalp, remember the psoriasis can be having the whitish plaques, but there will not be any kind of alopecia. Hair loss is not going to be associated with psoriasis. So now coming to the discussion of the histopathology of psoriasis. Remember important points in stratum corneum, hyperkeratosis and parakeratosis will be there. And in the stratum corneum, there will be collection of the neutrophils which we call as Monro's microabscess. So this is the picture where you are able to see the Monro's microabscess in the stratum corneum. Granulosum will be reduced or absent. In the stratum spinosum, remember there will be collection of the neutrophils which are now called as spongiform pustules of Kogoch. Spongiform pustules of Kogoch. So these are the neutrophilic which are collected in the stratum spinosum. Coming to the retar edges, they are elongated. So retar edges are elongated, and in the dermal papillary tips, we can see dilatation of the blood vessels. So these are all the important points which you need to remember associated with the psoriasis histopathology. So microabscesses, Monro's microabscess, neutrophils in the stratum corneum, spongiform pustules of Kogoch, neutrophils in the stratum spinosum. So here you are able to see the images: parakeratosis, spongiform pustules of Kogoch, and Monro's microabscess. All of these are shown. Coming to the treatment of the psoriasis, remember if the involvement of the body surface area is less than 10%, we can manage the patients with topical agents. Topical steroids are used. And if it is more than 10%, we can either use the systemic medications or the phototherapy. Any of them we can use. So in the drugs, remember methotrexate is the drug of choice for psoriasis vulgaris, chronic plaque psoriasis, psoriatic arthritis and erythrodermic form of psoriasis. Whereas the oral retinoid acitretin is the treatment which you are going to use in the patients of pustular psoriasis. And remember, the washout period for isotretinoin was 3 months or 1 month to 3 months. But in the case of acitretin, this is whooping 3 years. So if a woman takes the medication acitretin once, she has to be in having some kind of contraception for a period of 3 years. Very, very important point which you need to remember about acitretin. If a pregnant woman comes for the treatment of psoriasis, then what will you do? Methotrexate and acitretin both are teratogenic. So we do not have any other option except for using the steroids in such cases. Okay. So impetigo herpetiformis, pustular psoriasis in pregnancy, psoriatic erythroderma in pregnancy. So these are the two conditions in which steroids have to be used. We do not have any other option. Steroids, oral steroids, very, very slowly they should be tapered, because the patient again can go into the pustular psoriasis and erythrodermic psoriasis. If the pregnant woman is having some contraindication to steroid, like for example diabetes or hypertension, then cyclosporin is the next line of medication. There are some biological agents which are basically the monoclonal antibodies which can target specific T helper cells or the interleukin. So what are those? Remember, ustekinumab, it is going to target the interleukin 12 and 23. It is going to act on interleukin 12 and 23. Guselkumab, risankizumab, tildrakizumab. So I know you might be feeling, what are the names? Why are the names like this? Okay, they are going to associated with and act on interleukin 23. And TNF alpha inhibitor, infliximab, etanercept, adalimumab. And those which act on interleukin 17, they are, you can remember, SBI. Secukinumab, brodalumab, and ixekizumab, in which brodalumab is acting on interleukin 17 receptor. The rest too, they are going to act on interleukin 17. And of course, ixekizumab, some of these monoclonal antibodies are actually being tried on the patients of the psoriasis. And they are very much expensive. That is a problem with them. And you need to know some adverse drug reactions to these medications. Like for example, the PUVA therapy, that is psoralen and UVA, can produce the risk of squamous cell carcinoma. Very important. Cyclosporin, it is having a complication that it is nephrotoxic and it can also produce hypertension. Methotrexate, it is abortifacient and it is also associated with toxicity of liver. Acitretin, mucositis and hyperlipidemia. Just like isotretinoin can derange the lipids, here this acitretin can also derange the lipids. And recently there are some medications which are being used, phosphodiesterase 4 inhibitor, apremilast, and JAK inhibitor, JAK-STAT inhibitor, tofacitinib. These are being tried and used in the patients of the psoriasis. So these are all the medications: methotrexate, apremilast, tofacitinib, acitretin. Okay, just few points related to psoriasis. It never involves the central nervous system and it will not involve the mucosa, unlike the lichen planus, which is going to affect the mucosa. And there will not be any itching in psoriasis patients, and of course there will not be any hair loss, no alopecia. And if the mucosa is going to be affected, just remember this term, geographic tongue, might be seen in these patients. And of course, Auspitz sign, we have seen that it is positive in the psoriasis, but there are some types of psoriasis which are going to show Auspitz sign negativity. So what are those? Inverse psoriasis and pustular psoriasis, and also the guttate psoriasis. So these are the examples for type of psoriasis where Auspitz sign is negative. Next condition is lichen planus. So remember, this is a chronic yet a self-limiting condition which can heal within a period of 1 to 2 years. This is again a immune-mediated disease which is going to involve not only the skin, but it can also produce inflammation and the involvement of the mucosa and also the hair follicle. Very important. So what are the important provocative factors? The most important one you need to remember is a dental amalgam, which is basically the mercury containing component which is going to be used to fill the teeth. dental fillings it is used, and also certain infections like hepatitis C and B, and also some medications like, for example, anti-malarials, ACE inhibitors, and beta blockers. So here you are beautifully seeing the amalgam which is producing the mucosal lichen planus. So this is a mucosal lichen planus which will manifest as whitish Wickham striae. So reticulate pattern of whitish streaks can be seen in the mucosa in lichen planus, very important. And of course you all know that lichen planus is associated with some peas. Okay, what are those peas? Patients are going to have extreme itching, pruritus will be there. The lesions are purple or violaceous in color, and they are having polygonal shape, and the lesions can be papules or blocks, and of course they are plain topped. That is the reason why this is called as lichen planus. And you can add some more piece here itself, so lesions will be seen over the flexor aspect, but instead of flexor, for me, remember it as flexor aspect. So this is another P. So here you are able to see these are papules and some blocks present over the flexure area. And this is the surface of the lesion of the lichen planus, which is going to show this beautiful reticulate or network-like pattern. And this is called as Wickham striae. This is called as Wickham striae, which is whitish reticulate network-like pattern. This can also be seen over the lips, not only just the skin, also it can be seen over the mucosa also. And this is the Koebner's phenomenon. I hope you all remember by this time PSLV. Koebner's phenomenon will be seen positive in this condition. So in the mucosal involvement, remember there can be 30 to 70% of the patients of lichen planus having the oral lesions. And of course, this is reticulate lacy white pattern. And there is one type called as ulcerative or erosive type of lichen planus, where erosions and ulcers can be seen. And what is important, the patient should be monitored very carefully because they can become malignant. These are pre-malignant lesions. Coming to the nail involvement, remember the most common nail finding in the lichen planus is going to be thinning of the nail plate. Because of the constant scratching by the patients. Okay, and the most characteristic nail finding seen in pterygium in lichen planus is going to be pterygium of the nail, where there will be wing-shaped or triangular-shaped fold present. And what is this basically? There will be extension. This is the proximal nail fold. This proximal nail fold will extend, destroy the nail plate and attach itself onto the nail bed. So this is what is called as pterygium. Coming to the hair involvement, I hope you do remember that in this scarring alopecia, we have discussed this lichen planopilaris, where we are going to see the lichenoid papules in the perifollicular skin, and also we are going to see the scaling in the skull. Coming to the biopsy findings of the lichen planus, very, very important biopsy findings. So in the stratum corneum, what are we going to see? Thickening of the stratum corneum can be seen. Hyperkeratosis. In the stratum granulosum, opposite to that of psoriasis, here there will be thickening of the stratum granulosum, which is called as wedge-shaped hypergranulosis. And in the reteriges, one very important finding which you need to remember is sawtooth reteriges. Just like how a sawtooth will appear, the reteriges will become so much sharp in the patients of lichen planus. And the reason behind this is, just remember, in the dermis, the cells, that is lymphocytes, are going to be present in a band-like fashion. Lymphocytes, they are going to cause damage to these reteriges, stratum basal cells, because of which the reteriges, they are going to become sharp in nature. So that is the reason why we have sawtooth reteriges. So these are the actual histopath images which are showing the wedge-shaped hypergranulosis. And here in this image, you are beautifully seeing this sawtooth reteriges. And yeah, this is again the same thing. This is the same picture we have seen this. And in this picture, you can see that in the stratum basal. So this is first let me give you the orientation. Epidermis, dermis. So in the epidermis, in the stratum basal layer, you are able to see there is space produced because of the damage of the lymphocytes to the stratum basal. There are spaces produced. These are called as Max-Joseph spaces. And remember, the lymphocytes, they will reach the epidermis from the dermis, and they are going to cause the apoptosis of the keratinocytes. Apoptotic keratinocytes are referred to as civate body. They are referred to as civate bodies. Okay, these are the important findings in the histopath of lichen planus. So I don't want peace, I want problems always. So there are so many P's, we have discussed some of them already, but remember there are some more. Like for example, we have discussed the pterygium. And in the nails, remember there is a puptent sign. What is this puptent sign? So the nail will appear like a tent. Nail will appear like a tent. This is called as puptent sign. And finally, the lesions are going to heal with a very, very bad pigmentation. Very, very bad pigmentation in the patients of lichen planus. Coming to the treatment portion, remember limited condition can be treated with topical steroids. And if the condition is widespread, then we have to use systemic steroids. This was also recently asked. If there are 1 or 2 lesions or 1 or 2 sites, just give topical steroids, that will be sufficient. Okay. If it is extensive, phototherapy or the methotrexate dapsone, these medications can be used. Remember, limited disease, topical steroids, very important. So these are the differences or similarities between psoriasis and lichen planus. Both of them are chronic inflammatory papillosquamous disorders. But in psoriasis, there can be genetic association lichen planus, nothing of that sort. Itching is the most common manifestation in lichen planus, and it is almost absent in the patients of psoriasis. Hair involvement or lesions are classical of lichen planus, absent in psoriasis. Joint involvement is classical in psoriasis, absent in lichen planus. And these are the histopathological changes which I have shown you in the form of comparison, so that you can revise them. Okay. Next is pityriasis rosea. Okay, whenever you see the disease names, always try to dissect the terms. Okay, what is pityriasis? Wherever you see the term pityriasis, remember it is scaling. What is rosea? Rose like red color will be there. So rosea. So this is an acute self-limiting condition which is going to be self-resolving 6 to 12 weeks of time. And the most important etiological factor which you need to remember is human herpes virus number 7. So you will also remember this number 7 as we progress the number of slides. Okay, in the upcoming slides I will tell you how to remember that. The presentation is going to be usually asymptomatic or mild pruritus may be present, and the morphology or course of the lesions is going to be very, very crucial for you to remember. So the first lesion which we can see is called as mother patch or herald patch. So I will show you how it looks like. Once that herald patch is developed, after some time, like for example 1 to 2 weeks, there will be development of scaly papules and annular plaques, which are smaller in size when compared to the herald patch, almost all over the body, and most importantly, it is going to follow the Langer's lines. Very important point. Langer's lines are also called as relaxed skin tension lines. So this is how the herald patch or mother patch is going to appear, which is an annular lesion, and it is going to have a collarate or collar-like scale, just like how the collar will be there. So attached on the outer surface, and it is free on the inner surface. So this is the scale which is attached on the outer surface, and it is free on the inner surface. This is collarate scale. So inner edge is free, and after the lesion, this kind of a collarate annular lesion, which is herald patch having collarate scale, is produced, there will be development of multiple small daughter lesions along the Langer's lines, that is along the ribs on the posterior aspect of the body. So this is appearing like a Christmas tree. That is the reason why this is also described as Christmas tree pattern. So just remember this one image, you can remember all the points of pityriasis rosea. See, who is this Tala? Okay, Chennai Super Kings ka Tala, that is Dhoni. He is having this jersey number 7. With the help of that, you can remember the HHV 7. And what is the jersey number having? The name of Dhoni? No, it is having the name of their mother. Okay, Devaki and Sarojini. Okay, these are the mothers' names which they are wearing. So Virat Kohli and Dhoni, they are wearing the mother's names. With the help of that, you can remember herald patch or mother patch can be seen in pityriasis rosea. And what is another thing? They are wearing the t-shirts which have the collar. So collarette or collar-like scale is seen in pityriasis rosea, can be remembered. And why they are going back to the pavilion? Because they have won the match and they are taking the rose in their hands and they are going to celebrate the Christmas along with their family members. So this is how you can remember all the important points related to pityriasis rosea with the help of this single image. Okay. Next condition is pityriasis rubra pilaris. By this time you all know pityriasis means scaling and rubra means red color and pilaris means follicle. So there are going to be the follicle oriented erythematous papules. Perifollicular papules will be seen in these patients, which are going to be very, very rough in nature. Just like how the nutmeg grater will look like on touch, this lesion also is going to be very, very hard to touch, having scaling on the surface. And you need to remember that the progression of the lesions. Initially, the lesions are going to be present near the neck. Okay, so orange red erythematous changes will be present over the neck. So slowly from the face, neck, the lesions are going to show cephalocaudal progression, and ultimately there will be a point where more than 90% of the body surface area is going to be involved, and the patient may also land up into erythroderma. And there are going to be some islands of sparing. Some islands of sparing can be seen in these individuals, as you are able to see in this picture. Okay, and this is a nutmeg which is used in the spice of biryani, and this is a nutmeg grater. So like this, the lesions are also going to be very, very rough in nature. So there will be this cephalocaudal progression of this lesions, and the palms and soles are going to become very, very thick, which is called as palmoplantar keratoderma, or it is also called as PRP sandal, pityriasis rubra pilaris sandal. So from this slide, we are going to start the discussion of the eczemas, various steps of eczemas. Okay, so there is response of the skin to various endogenous, internal and exogenous stimuli in this condition, eczema. So remember, all eczema is dermatitis. All eczema is dermatitis, but not all dermatitis is eczema. So simply put, you should remember that dermatitis is an umbrella term. Dermatitis is an umbrella term which includes eczema and also other conditions. So we have morphological classification of the eczema as acute, subacute and chronic. In the acute, please remember, the patient's skin is going to appear as if it is boiling, So there will be all the inflammatory changes, vesicles, oozing, crusting and erythema. In the subacute form, there will be erythema and scaling. And in the chronic eczema, remember, because of the constant scratching, the skin is going to show one important safety or protective measure, in which the skin is going to show three important changes. What is that? It is called as lichenification, in which skin will be thick and it will become hyperpigmented, and there will be exaggerated skin markings. All these three changes, that is thickening of the skin, increased pigmentation and exaggerated skin markings, can be seen in this given picture. So this we have already discussed. In the stratum spinosum of the patients of acute eczema, there is going to be the collection of the fluid in between the cells, and you are able to see this is the normal histopath picture, where there is compact, there is no space between the cells, keratinocytes, it is compact. Whereas if you observe this image, which is of acute eczema patient, you are able to see that the keratinocytes are separated and there are spaces which are seen. These spaces are nothing but they are due to the edema, intercellular edema. And thickening of the stratum spinosum, that is acanthosis, is going to be seen. Stratum spinosum, that is seen in chronic eczema. Remember, in acute eczema we can see spongiosis, whereas in the chronic eczema we are going to see acanthosis. So next, depending upon exogenous factors or endogenous factors, we have various types of the etiologic classification of eczema. So remember, in the exogenous variety, we have this contact which can produce the dermatitis, which are ICD and ACD, and certain ultraviolet rays can produce a dermatitis, photodermatitis. Certain plants can also produce, which is called as phytodermatitis. So irritant and allergic, very important for you to know what are the differences. So irritant contact dermatitis, just remember this case scenario where I hope you all might have seen this movie Chapak. So if there is a acid, if there is contact with the acid or strong base, what will happen? The skin is going to damage. And yes, ICD is just like that. So all the individuals who are going to expose to these acids or alkalis, they are going to develop the irritant contact dermatitis. It is basically a non-immunologic condition where just the direct tissue damage is going to be produced, and it will be restricted to the site of the contact of the whatever irritants we are going to discuss. Okay, and the patients are going to complain of burning sensation of the skin. Whereas coming to the allergic contact dermatitis, remember allergic contact dermatitis is very important. It is going to be seen only in some genetically predisposed individuals, and it is example for type 4 hypersensitivity reaction. And these individuals do require a sensitization phase. That is, immediately after coming in contact with the allergen, there will not be any reaction. There should be one or two, repeated contact. Once or twice there should be a contact with that allergen. Then only initially there will be sensitization, and afterwards, if the patient is genetically predisposed, then there will be development of ACD. And this condition tends to disseminate beyond the site of the contact, and the complaint is going to be mainly itching. So irritant contact dermatitis, some of the examples which we need to remember are detergents which can be having mild acids or alkalis, and also this can be seen in the case of diaper dermatitis because of all the ultimate cocktail of the feces and the urine which have the urea and ammonia. So there is going to be irritation of the skin producing irritant contact dermatitis. And coming to the allergic contact dermatitis, very important, hair dye which consists of the PPD, paraffin diamine. This can produce not only the scalp involvement, it is also going to affect the rest of the body also, because ACD can disseminate. And you can see this was a previous question also, and the patients may also develop the edema of the eyelids and also involvement of the neck, and the rest of the body also can get affected. And of late, recently there are various products, hair dye products which are having PPD free, ammonia free hair color. In the metals, just remember the important nickel. This is the metal which is the most common cause for allergic contact dermatitis among the metals. So here you can see there will be a contact with the buckle or jewelry or the 1 gram gold, whatever it is. Okay. And this is the topical antibiotic neomycin or neosporin. They can also cause allergic contact dermatitis. In the cement, remember potassium dichromate is the allergen. In the bindi, if you remember the chemical leukoderma, we have discussed PTBP can produce bindi leukoderma. It can also produce the allergic contact dermatitis in the bindi area. So remember the important test, the investigation of choice for allergic contact dermatitis is patch test. And what is it working on? It is working on the principle of identification of type 4 hypersensitivity reaction. So we are going to apply the allergens over the patient's back, and we are going to see what will be the manifestation. So these are all the allergens which we are going to apply over the back of this patient, and we are going to take the 2 important readings. So the first reading is going to be taken after 2 days. That is 48 hours. But the best reading is going to be taken on 4th day after the patch application. That is 96 hours after the application of the patch. And this can be the finding of the site of the patch test. It can be red or vesicles formation, or it can be absolutely normal if the patient is not having any allergy to any other compounds, Next, we have the airborne contact dermatitis. So it is not anybody can dance, it is airborne contact dermatitis. So in which basically substances are present in the air. They can be pollen, they can be some kind of chemicals. Okay, we are going to discuss in this particular slide the airborne contact dermatitis due to a plant. So this substance will settle down and it is going to produce a dermatitis over the exposed parts of the skin. So what is the plant? We are going to discuss Parthenium hystophorus, which is also called as Congress grass or Congress weed. which consists of this important allergen which is called as sesquiterpene lactone, SQL, which is present in the pollen. It is going to get deposited over the exposed areas where there is going to be dermatitis changes in the patients. Now coming to the endogenous varieties of eczema, there are so many of them. Seborrheic dermatitis we are going to discuss as the first one, which is the inflammatory response of the seborrheic areas of the body to Malassezia furfur. It is also called as dandruff if it is mild form. So where can we see the lesions? Wherever the seborrheic areas are high in concentration. So important one you need to remember is nasolabial folds. The nasolabial folds which you are able to see in this patient, you are seeing very beautiful inflammation. You are able to see the inflammation is present, and also you are able to see the yellow greasy scales. The yellow greasy scales is the very important term, and it was observed that seborrheic dermatitis occurs in a severe form in the patients of Parkinson's and HIV infection. And if the seborrheic dermatitis occurs in the infants over the scalp, it is called as cradle cap. So are you able to see this beautiful child having this cradle cap? Next is stasis eczema. This was recently asked. Just remember, if a person is having this gravitational, varicose veins, basically varicose veins, if they are present, what will happen? Skin will also show the changes, and this is what is referred to as stasis eczema, or this is also called as gravitational eczema. So in this, you can remember chronic venous insufficiency is going to be associated with this. And you should remember that there is one classification which is going to be discussed in your surgery, SEEP classification. So in that SEEP classification, where does the eczema stand? It is going to be present in the C4A. The pigmentation and the eczema is C4A, whereas the inverted champagne bottle appearance, which you are able to see here, that is lipodermatosclerosis, it is kept under C4B. Very important. It was asked in the recent NEET examination. So lipodermatosclerosis. The next endogenous eczema is pityriasis alba. Pityriasis, wherever you see this term, remember it is scaling. Alba is white. So in children it was observed that they were having hypopigmented scales over the face. And the important differential diagnosis for the pityriasis alba is, remember, indeterminate leprosy. In both these conditions, child can come with facial hypopigmented macules and patches. How to differentiate? Very simple. Pityriasis alba is going to have multiple lesions. That is one point, and there will be scaling associated in the patients of pityriasis alba, whereas scaling will be absent, and usually it will be a single lesion in the case of indeterminate leprosy, and skin is also going to show atrophy in indeterminate leprosy. So these are important points related to pityriasis alba and indeterminate leprosy. So here you are able to see multiple hypopigmented lesions over the face. But here in indeterminate leprosy, we are able to see only single lesion. So this is pityriasis alba. Nummular eczema, you might be remembering the discoid eczema is the other name for this condition, and you are able to see the coin-shaped lesions will be there in this condition. So this is how the discoid eczema going to appear with activity everywhere in the center as well as in the periphery. Next is phompholix. This is also called as dyshydrotic eczema. And remember, in this, clinical features are very important. Intensely itchy and also painful deep-seated vesicles can develop at the sides of the digits. And they are going to have this sago grain-like appearance, and most common in people with the history of atopy. Most common in the people who are having this history of atopy. Phompholix dyshydrotic eczema will have the sago grain appearance. Sago grain tapioca, from which we get this sago grain. It's also called as sabudana in Hindi. So similar appearance is seen in these patients over the sides of the digits. So it is called as phompholix. Next condition which you are going to see is atopic dermatitis. So remember, it is a chronic relapsing inflammatory skin disease, and it is classified. It is very interesting. It is classified as an endogenous eczema, which is triggered by certain exogenous factors. So let us look at the few important points related to atopic dermatitis. It is a localized form of type 1 hypersensitivity reaction, anaphylaxis, atopic dermatitis. So these are all belong into type 1 hypersensitivity reaction. And there will be three important features, that is a triad of features. So in the upper respiratory tract, remember there will be allergic rhinitis. In the lower respiratory tract, bronchial asthma will be seen and skin will show allergies, that is atopic skin changes. So these are the three features. And there are three phases in atopic dermatitis: infantile phase, childhood phase, and adult phase. So in the infantile phase, remember the birth to 2 years, the child is going to have the dermatitis changes where they are going to be seen over the face and most importantly over the extensor aspect. So extensor aspect is involved because the infants are going to crawl and there is going to be damage of the extensor area. So there is going to be eczematous skin changes. So next is childhood phase, that is from 2 years to puberty. So there are going to be red oozy papules and plaques in the flexural areas, so cubital and popliteal fossa. So this is called as childhood phase of atopic dermatitis. Now coming to adult phase after puberty, the lesions are going to be same flexural areas, but now they are going to become lichenified, increased thickness, increased pigmentation. Okay, these changes are going to be seen in the adult phase of the atopic dermatitis. So this is infantile phase. See, small child who is having the cheeks which are having eczematous changes, and also because they crawl they are going to have the extensor areas having these eczematous changes. And childhood, the popliteal fossa and also antecubital fossa, the flexures are going to have these changes. Coming to the diagnosis, very important, it is diagnosed with the help of not any investigation but with the help of clinical examination, which is the investigation of choice. And there are four important major criteria which you need to remember in the Hanifin-Rajka criteria. What are those key diagnostic criteria? So first one is pruritus, itching is the hallmark of atopic dermatitis. If it is absent, then we can straight away say it is not atopic dermatitis. Okay. Next is typical morphology and distribution. We have just now discussed the three phases: infantile, childhood, and adult phase. It is a chronic or chronically relapsing dermatitis. This we already know. That is also one of the criteria. Personal or family history of atopy is also very important. Okay. So the pruritus is a hallmark and it should be intense intermittent variety of itching, which should be seen in these patients of atopic dermatitis. This is typical morphology, and this is chronically relapsing. So lichenification should be checked over the skin. And personal family history of atopy, that is the mother, father, siblings, they are having allergic rhinitis, they are having bronchial asthma, they are having atopic dermatitis. Ask in the history. And there are certain minor criteria also in atopic dermatitis. Remember, there will be dryness of the skin, which is called as xerosis, and there will be ichthyosis, that is fish-like scales. Fish-like scales can be seen. And in the atopic dermatitis, we can see one peculiar observation, that is usually dermographism. I hope you all know that it is seen in urticaria, where we can write over this normal skin of the patients, where we see the red color of the skin. It is dermographism. Whereas here in atopic dermatitis, one interesting white dermographism can be seen. So what does this mean? On stroking the skin, there will be white line which will be seen over the skin. Are you able to see these white lines? Okay. So this is called as white dermographism. Basically, the underlying problem here is because of the excessive vasoconstriction. Wherever there is trauma, vasoconstriction is occurring. So there is white dermographism. Okay. Next is this headlight sign. Simple. The child, if you observe over the cheeks are going to be very, very red in color, just like the headlights. So that's the reason why it is called as headlight sign. And there is sparing of periorbital, perioral, perinasal areas. So this will appear prominent like headlights. And in ophthalmology, remember the cornea are cone-like keratoconus. And you can see the allergic shiners and allergic solute. This is the allergic solute, always doing like this because they are having irritation. Okay, because of which there will be hyperpigmentation over the nose. And this is the allergic shiners where there is erythematous changes in the periorbital area. So this is shield cataract, which is anterior subcapsular cataract, which can be seen in the patients of atopic dermatitis. And in the infraorbital area, there is going to be a small fold, very important name, which is called as Denny-Morgan's fold. Denny-Morgan's fold, which can be seen in the patients of atopic dermatitis. And if you remember, we have seen the term madarosis in the frontal fibrosing alopecia. Here we can see in the atopic dermatitis lateral matarosis, where there is loss of the eyebrows. This is also called as, very important name, Hartog sign. And there is one syndrome associated with the atopic dermatitis or eczema. So what is it? It is called as Wiskott-Aldrich syndrome. But we are going to change the name of this condition into Wiskott-Aldrich syndrome. And what is the patient going to drink? It is water. It is just the water. It is not the alcohol or another beverages, cool beverages. Okay, it is water. It is basically Wiskott-Aldrich syndrome is an X-linked recessive inherited condition which is going to have the WATER features. W stands for WASP gene mutation. WASP gene mutation. A is there is defect in the antigen presenting cells. Because of this defect, the patients are going to have recurrent infections. And of course, we are discussing it in the atopic dermatitis. So eczema or atopic dermatitis, like skin changes will be seen. What is another feature? The patients are going to have thrombocytopenia, small platelets, microthrombocytopenia will be there. These are all the features associated with Wiskott-Aldrich syndrome. Very important. Treatment of atopic dermatitis, simple. Moisturize the skin with emollients because otherwise dry skin will be seen, and give topical steroids which are having anti-inflammatory activity for these patients. And now coming to next condition, which is urticaria. So this is a histamine mediated condition which is IgE mediated, and it is an example of type 1 hypersensitivity reaction. And the usual, if you remember, if we give a stroke to the normal skin, what will happen? There is going to be the wheel flare response. If you remember, this is called as triple response of Lewis. So in the patients of urticaria, there is going to be development of these wheals because of the mast cell degranulation and the production of the histamine, release of the histamine, which is the important mediator in the urticaria. So we are going to see the patients having transient wheals over the body, and they are called as transient because they will be seen less than 24 hours. They will disappear after 1 day usually. Okay, and I have already told you skin graphism is ability to write. Okay, if the normal skin, if it is given a stroke, then because of the underlying mast cell degranulation, there will be histamine release and there will be normal wheel flare response along the lines wherever we have written. So somebody, very cleverly has written dermographism itself over the body. So this is what is called as dermographism, which is ability to write on the normal skin. Okay, remember this term, normal, very important. So we have seen this already. The urticaria lesion is going to have a central pallor and a peripheral erythema. So this is the angioedema, which is also called as Quincke's edema. Remember a few important points. It is due to C1 esterase inhibitor deficiency, because of which there will be non-itchy but painful swelling appearing over the body. And here the edema is going to be at a very deeper level. It is subcutaneous level. And you might have seen this movie Hitch, in which there was this Will Smith developing the swelling of the periorbital and also the lips after the intake of the seafood. Okay, so this is hereditary angioedema, which is an autosomal dominantly inherited condition, which is going to be, of course, familial, and there will be sudden development of this condition where there will be a recurrent episode of non-pitting type of edema. Patients do not have any wheals, urticaria or itching. Okay, all these symptoms will not be there. The only problem is going to be the development of the edema, recurrent edema. And if this condition affects the subglottic area, then there is a possibility of the airway blockage during one of the episodes of hereditary angioedema, which can turn out to be life-threatening. So always these patients are going to be having very close monitoring as much as possible. The next condition is called as cutaneous mastocytosis, which is also called as urticaria pigmentosa. So basically in this condition, there is going to be mast cell proliferation. Usually this is seen in children. And how does the skin lesions appear? They are going to be seen as hyperpigmented macules, which are able to see here, brown hyperpigmented macules and patches present over the body. And below these patches, they are mast cells which are proliferating. That is the reason why the skin is appearing brown color like this. If you have to do the biopsy to identify what is the stain which we can use, it is toluidine blue. The lesions are seen in children over the trunk, and one important sign is associated with cutaneous mastocytosis or urticaria pigmentosa. What is that? It is called as Derriere sign. Remember, in the urticaria, if we stroke the normal skin, there will be development of wheal response. But in the case of cutaneous mastocytosis, interestingly, the lesional skin, if it is given a stroke, there will be a release of histamine. Because of the release of the histamine, there is going to be a urticarial wheal which is going to develop at the site of the this trauma. So this is what is referred to as Derriere sign. Very, very important. So whenever we rub the lesional skin, then only there will be development of this urticarial halo developing at the site of the trauma. This is called as Derriere sign, and it has nothing to do with, not associated with Derriere's disease. So some students might get confused with the Derriere's disease. So it is not having any association with the Derriere's disease. Please remember this very important point. Next, we are going to discuss the genodermatosis, which are also called as pacomatosis. So simply put, genodermatosis, genetic conditions which have the skin manifestations are called as genodermatosis. Okay, so neurofibromatosis, tuberous sclerosis complex are important ones for you to remember, and along with this we are also going to cover the ichthyosis topic. So neurofibromatosis, simply put as NF, there are two types. Okay, there are so many almost 8 to 10 types of neurofibromatosis, but for exam point of view, 1 and 2 are important. So NF1 is also called as von Recklinghausen's disease, and remember, the NF1 neurofibromatosis, how many letters are there in that count? They are going to be 17. So it is NF1 is associated with chromosome 17, and the protein which is having defect is neurofibromin. Whereas in the case of neurofibromatosis type 2, remember the chromosome number is 2 to 22. Okay, and it is also called as MISME, multiple inherited schwannomas, meningiomas and ependymomas, MISME, and it is due to defect in the Merlinar schwannome. So here is a radiology image of the NF2 which presents as bilateral acoustic schwannomas. Coming to the features of neurofibromatosis type 1, the first finding which you need to remember is neurofibromas. So usually seen in the adolescents, the lesions of neurofibromas are going to be soft, skin-colored, non-tender papules and nodules, which you are able to see so many, papules, so many nodules are there over the body. And basically, what is the basic problem here is these are all the benign tumors of the connective tissue of the peripheral nerve sheath. PNS is not parasympathetic nervous system; it is peripheral nerve sheath. And there is one more named sign which you need to remember in the NF1. It is called as buttonhole sign. So pressing the neurofibromatosis is going to give a giveaway feel. So as if the lesion is going inside the skin, but as you remove the finger, the pressure, the lesion of neurofibroma will again rebound. So just like how in the button we put in the hole we put the button and again we take it off, like that the finger is going inside and coming outside. So it is called as buttonhole sign. Next is plexiform neurofibroma. This is very important. It is seen from the birth. And how does it appear? It will appear as a diffuse expanding plaque, and it is due to the multiple nerve fascicle involvement. If you try to palpate, it will give a bag of worms feel on palpation. Cafe ole macules are the other changes which we can see over the skin in the form of hyperpigmented macules, and the size and also the number of the cafe ole macules is also important. In short, we write them as CALM, and in the pre-pubertal age group they should be more than 5 millimeters. In the post-pubertal age group they should be more than 15 millimeters in size, and they should be more than or equal to 6 in number over the body for us to diagnose them as patients of NF1. We have already seen this in the skin freckling. Okay, it is seen over the photo-exposed areas. But remember, in neurofibromatosis type 1, very peculiar freckling will be there, which is seen in the axilla. Okay, axilla is going to show these freckles, and this is pathognomonic for NF1, and it is called as Crowley sign. It can also occur in the groin also, and you are able to see this is a cafe ole macule here. So these are some of the important points kept in the tabular form for you to revise. So in the ocular manifestation, remember this very important finding, very, very important finding, which was asked recently also in the FMG exam. Lish iris nodules. Basically, these are the iris hamartomas. These are the iris hamartomas, which can be seen with the naked eye also, but slit lamp examination is going to be very, very helpful in identification of very small Lish nodules also. And visual acuity is going to be absolutely normal. Only thing is, okay, we can clinically or with the help of slit lamp see these iris hamartomas. Okay. So this is another finding where optic pathway glioma can cause the proptosis of these patients of NF1. Next condition is tuberous sclerosis complex, which is also called as, in short, as TSC, and it is also called as epiloia. Epiloia. What is epiloia? Epilepsy, low IQ, A is adenoma sebaceum. So epiloia, or it is also called as a triad, which is Vox triad, which is called as Vox triad. So basically, this condition is going to have the important skin features, which you should remember. Major skin features are very, very important to remember. Ash leaf macules, adenoma sebaceum, shagreen patch, covenant tumor. So how does they appear? So this is the ash leaf macules which are able to see. The earliest skin finding is this ash leaf macules, which appears like this. At one end, it is going to have the oval shape, and at the other end it is going to be sharp in nature, pointed. This is described as lance ovate shape, and this can be seen with the help of Wood's lamp. If it is clinically not visible, if we throw the Wood's lamp, the ash leaf macule is going to become evident. Next is adenoma sebaceum. It is a characteristic lesion of the epiloia, that is tuberous sclerosis, and it is basically the facial angiofibroma. So adenoma sebaceum is a misnomer. It should have been called as angiofibroma. Why? Because there will be proliferation of the blood vessels and the fibrous tissue in these lesions. And the lesions are going to be symmetrical reddish brown papules, as you are able to see here in the central portion of the face. The adenoma sebaceum or angiofibroma is seen. Next, shagreen patch is another lesion which you need to remember, which is basically a leathery block located over the lumbosacral area. And if you do a biopsy, we can see that there will be a proliferation of the collagen in the skin. Next, we have the fibromas, okay, which are periangular fibromas, which are also called as covenant tumor. Remember, by looking at this term, periangular fibroma, don't jump into the conclusion that it is seen in neurofibroma. Okay, remember, very important. Periangular fibromas are seen in tuberous sclerosis, and these are the periangular fibromas, the growths which are able to see adjacent to the nails. So all the features of the tuberous sclerosis you can remember with the help of this simple mnemonic, which is ask me Segar. So ash leaf macules, adenoma sebaceum, shagreen patch, covenant tumors, mental retardation, because of which there will be low IQ. So in the epiloia, low IQ. Epilepsy, Sega is subependymal giant cell astrocytoma, subependymal giant cell astrocytoma, and rhabdomyoma. So these are all the findings which we can see in the patients of tuberous sclerosis complex. Next is Stooge-Weber syndrome. This will be discussed in detail in the pediatrics. So just I want to give you few important points related to dermatology. So basically in the dermatology, we are going to see the facial port wine stain, which will appear as pink, red over time, turning into purplish color later in the life. Remember this port wine stain, which is you are able to see here in this picture, it will stay for lifetime. It is permanent, but we have treatment modalities with the help of PDL, which is pulsed dye laser, We can treat these port wine stain lesions. Next is ichthyosis. Ichthyo, wherever you hear, I hope you remember it is fish-like scales. So there are various causes for ichthyosis. It can be congenital or it can be acquired. In the acquired, remember one important cause, which is the leprosy. Okay. This is very important, which you need to remember. And in the congenital, you can remember 3 important conditions which we are going to discuss now. Ichthyosis vulgaris, X-linked ichthyosis, and lamellar ichthyosis. If you remember, in dermatitis herpetiformis, we have discussed about this lamellar ichthyosis. If you remember, very good. So ichthyosis vulgaris, the inheritance patterns is autosomal dominant in nature, and the age of onset is 3 to 12 months. And the basic defect, if you remember, in the basics, we have seen filaggrin, filament aggregating protein, is problematic in ichthyosis vulgaris and also in atopic dermatitis. So this is the defect here. And what will be the clinical features? So here you are able to see this is stratum granulosum, keratohyalin granules, atopic dermatitis, and ichthyosis vulgaris defect in the filaggrin protein. So fine white scales will be there in ichthyosis vulgaris, and there will be certain associations which are keratosis pilaris and hyperlinear palms. So keratosis pilaris is chicken-like skin, and hyperlinear palms, there will be increased dermatoglyphics in the palms. Now coming to the X-linked ichthyosis. So it is also called as ichthyosis nigra. Nigra, wherever you hear this term, remember it is black or dark, associated with black or dark. What is it associated with black or dark? We'll see in the next slides. Okay, it is an X-linked recessive condition. The defect here is going to be in the steroid sulfatase. So I told you nigra is black, so there will be black colored scales in these patients of X-linked ichthyosis. The associations are also very important. Both of them start with the C alphabet: corneal opacities and cryptorchidism. Very, very important findings which you need to remember associated with the X-linked ichthyosis. Okay. So this is a picture of the X-linked ichthyosis where you are able to see this ichthyosis nigra, that is the dark colored brown or black colored scales. Next, we have very important lamellar ichthyosis, which is also described as ARCI, autosomal recessive congenital ichthyosis. And basically here there is one important term which you need to remember, which is called as collodion membrane, which is also called as parchment-like membrane. So in this, children, it was observed that there is going to be a membrane which is going to cover the entire body. I will show you how it looks like, but before that, just remember the defect here is going to be in epidermal transglutaminase number 1. So in dermatitis herpetiformis, it was ETG number 3, which was having a problem. So here we are going to see dark plate-like adherent scales over the body. Once the collodion membrane is lost, we can see this adherent plate-like scale over the body, and this is associated with ectropion and eclabium. So these are the important findings. I will show you the image. Probably you will not forget these children. Okay, so this is the collodion membrane, which can be seen from the birth. It is also called as parchment-like translucent membrane. And usually after 1 month, the membrane will be lost, and the scales which are present inside underneath the membrane will become evident. So in this picture, you can see the ectropion and the eclabium. So here, this is the eyelid involvement. You are also able to see that there is also lip involvement. So this is a question which was asked in the latest exam. So child presents with scaly dry skin since birth. He has a collodion membrane. What is the diagnosis? Very simple. It is lamellar ichthyosis. Okay. So remember autosomal recessive congenital ichthyosis. So these are the following examples. In all of them, we can see this collodion membrane. So lamellar ichthyosis is one. Other types can be bathing suit ichthyosis, collodion baby, harlequin ichthyosis. These are the important which I have highlighted. Okay. So you need to know few points about harlequin ichthyosis also. It is an autosomal recessively inherited condition due to the ABCA12 gene mutation. And the patients are going to have a very, very poor prognosis. You are able to see this beautiful ectropion and eclabium, but it is very disturbing image to see. So ultimately, the patients are going to succumb and they are going to die most of the times. The treatment, we are going to use topical emollients and systemic retinoids. Okay, thank you so much, students. I hope all of you enjoyed this. Try to revise as quickly as possible whatever you have read in this particular session. Hello, dear students. So in this video, we are going to see various infections which can present over the skin, which are going to be bacterial, mycobacterial, fungal, viral, parasitic, and of course, the important one, leprosy. So let us discuss all these one by one. First, we'll start with the bacterial infections, in which we're going to discuss the pyodermas. So what does pyodermas means? Pyo is pus, derma is skin. So in the skin, if bacterial infections are producing the pus-filled lesions, we are going to call them as pyodermas. And remember, we have two classifications, broad classifications. One is follicular pyodermas and the another one are non-follicular pyodermas. So the bacterial infections, if they are associated with the hair follicles, we call them as follicular pyodermas. If they are not associated with the hair follicles, we call them as non-follicular pyodermas. So in the follicular pyodermas, you must remember some important points. First one is, what is the causative agent? It is Staph aureus. And what are the examples? Folliculitis, furuncle and carbuncle. So here we have two uncles with us. One is furuncle and the another one is carbuncle. So coming to clinical features of the folliculitis, here the funda is very simple. Infection of the hair follicle. So if you see, these are all the hair follicles just surrounding which you are able to say that there is a pustule. Okay, so this is the folliculitis. Now coming to furuncle. So what is furuncle different from folliculitis? Here, not only the hair follicle but also perifollicular area will appear red, tender and nodular. So this is the hair follicle. You are able to see a pustule is present, but also you are able to see perifollicular skin is becoming nodular. Okay, this is furuncle, or in layman terms it is called as boil. Next is carbuncle. So just remember, infection of the group of multiple hair follicles with contagious area, that is adjacent surface of the skin also being involved. This is what is called as carbuncle. And I hope you might have seen these patients in your surgery wards. Most likely these are the individuals who are going to have a uncontrolled diabetes mellitus, because of which there will be extensive follicular pyoderma. Where is going to be seen? It is going to be classically seen over the nape of the neck. This is classical side. And what is the lesion? You are able to see there is going to be a erythematous tender plaque which will have discharging sinuses. You are able to see these are the multiple discharging pus points. This is carbuncle. Treatment will be with incision and drainage. Next, we are going to see one special type of folliculitis which is called as psychosis barbae. Okay, this is site-specific type of folliculitis where the site is going to be barbae. Wherever you hear this term barbae, remember it is going to be beard area, and it is going to produce a non-scarring pyogenic infection. So you are able to see there are multiple pustules present over the beard area. The good news is that it is a non-scarring pyogenic infection. So hairs will be retained. Hairs are not going to be destroyed. Now let us discuss about the non-follicular pyodermas. Very, very important topic. Many questions are being asked on this particular topic. Okay. Here hair follicles are precisely not involved. Okay. So classification is localized or spreading or diffuse varieties. In the localized, remember we have impetigo and ecthyma. And in the spreading, remember we have erysipelas and cellulitis. So in this picture, you can see that in the impetigo, the layer of the skin which is going to be infected or involved is epidermis. Ecthyma is a, just remember one point, it is a deeper variant of the impetigo which is going to even involve the dermis. And in the erysipelas, remember we are going to see the involvement of dermis and also the lymphatics. In the cellulitis, remember the infection is going to be very deep, pretty deep in the subcutaneous tissues. So what is this impetigo? It is a bacterial infection of the epidermis. So we have two types of impetigo. One is non-bullous impetigo and the another one is bullous impetigo. Non-bullous impetigo is also called as impetigo contagiosa. And here the etiological agent, most common one is streptococcus, which is group A beta hemolytic streptococcus. Staph can also be one of the etiological agent. But remember, because strep is involved, so there is a dreaded complication which you need to remember, which is called as post-streptococcal glomerulonephritis. And how does it manifest clinically? The patients are going to be usually the children. Over the face, we are going to see very, very important crust, which is golden brown or honey colored crust, which you are able to see here. This is the golden brown or honey colored crust seen in the non-bullous impetigo. Coming to bullous impetigo, remember the causative agent is always and always staph staphylococcus, and it is going to produce certain toxins, which is exfoliative toxin A and exfoliative toxin B, which in short you can remember it as ETA and ETB. So basically what this toxin is going to do is this is going to destroy the desmoglein 1. Desmoglein 1, I hope all of you know, 1 tries to be in the top epidermis, stratum corneum layer, so subcorneal split is going to occur. That is the reason why there will be bullous lesions in this impetigo. Okay, and where are we going to see this? In the children, usually face and also trunk can be involved. So here we are going to see the flaccid bullae, and once they rupture, they are going to leave behind the crusting, which is described as varnish colored crust. You are able to see these are the bullae which we can see, and this is the varnish colored crust which you are able to see here. So this is a picture of the golden colored crust which you are able to see in the impetigo contagiosa. Very important color which you need to remember related to impetigo contagiosa. Next, in the bullous impetigo, just remember that these lesions can appear like this. Okay, half of the lesion which is present due to the gravity, the lower half of the lesion is going to have the pus. Okay, this is what is referred to as hypopaeonsen. The pus settles in the lower half of the bulla due to the gravity, because of which it appears, if I hope you remember hypopaeonsen in your ophthalmology, just analogous to that we have the hypopaeonsen in bullous impetigo. So this is another picture where you are able to see the varnish chocolate colored crust. These are all the topical antibacterials which are going to be sufficient for the treatment of impetigo. Fusidic acid, mupirocin you are able to see, retapambolin and ozenoxacin. So next we are going to see the spreading infections. Remember, most important ones is erysipelas. Okay, just like in the bullous impetigo, the causative agent was only and only staphylococcus. Likewise, here also in erysipelas, the causative agent is going to be only and only group A beta hemolytic streptococcus. So these are very important for you to remember. And in erysipelas, we have to remember the other name as Saint Anthony's fire, and here the involvement will be in the dermis and also in the lymphatics. And there is going to be hyaluronidase responsible for the easy spreading nature of this infection. And how does it manifest? This is very important. Clinically, there will be well-defined raised margins with clear demarcation between involved and the normal skin. If I show you the image, clinically you will easily remember this. So this is a patient of erysipelas. You are able to see this is the normal skin, and this is the involved skin. You are able to clearly demarcate between the involved diseased skin and the normal skin. But whereas coming to cellulitis, this is a patient of cellulitis. What is that you are able to see? That there is diffuse erythema. So you cannot actually draw a line and say that yes, this is the normal skin and this is the involved skin. So this is how cellulitis is going to present. What is the reason behind this? Because in cellulitis, the infection is going to be deeper. So that is the reason why the definitions or that is the margins are going to become ill-defined. And here the causative agents can be streptococcus as well as staphylococcus. Nothing specific in that. And here you can see this is a picture depicting cellulitis which is having the deeper subcutaneous tissue infection. And here erysipelas, it is not going to involve the subcutaneous levels. It is only going to be the dermis. And in the erysipelas, remember one more point. The face, if it is having erysipelas infection, then the ear can also be involved. Ear involvement can be seen in the patients of erysipelas. Whereas in cellulitis, because in the pinna, deep dermis is absent. So that is the reason why cellulitis will not affect the ears. Important point. This is what is called as million ear sign. Right. Next, we have the staphylococcal scarlet skin syndrome, which is also called as Ritter's disease. The other name is also very important to remember. So in this condition, basically, we are going to see exfoliation of the skin. And this is due to the toxins produced by the staphylococcus. That is the reason why it is called as staphylococcal scalded skin syndrome. It is called because the skin will appear as if it is burnt. Okay, I hope you remember from the forensic medicine, Gurudev sir, Atul Gupta sir, what is a scalding. So if hot water falls on the skin, we are going to see the scalding type of a skin lesions. So etiological agent, obviously it is staphylococcus, and the exotoxins produced by this staphylococcus, that is exfoliative toxin A and B, are responsible for this. And we have seen this in the bullous impetigo. Okay, not only the bullous impetigo could be a source of this staphylococcal scarlet skin syndrome, even the infection of the ear or conjunctiva can also be a reason for this syndrome. And here, of course, epidermolytic toxin or exotoxin is going to spread and become generalized because it will spread through hematogenously through the blood. And finally, what it will do, this toxin is going to target the desmosome, specifically desmoglein 1, and it is going to produce what is called as acantholysis. I hope you remember this concept of acantholysis. And yes, next we are going to see the child. This is going to involve the children, where we are going to see initially fever, and later on there will be tenderness in the skin, because of which the child is going to be very irritated, always crying. So what are the steps? So staph aureus infection, epidermolytic toxin or exotoxin, and there is going to be hematogenous spread. This will target the skin, reach the desmosomes, destroy the desmoglein 1, and ultimately there will be subcorneal split, and the skin will be very tender. That is the reason why pain will be there. And finally, we are going to see epidermolysis, that is sheet like epidermal peeling. By listening to this term epidermolysis, maybe you have remembered this disease, toxic epidermal necrolysis. Very good if you have remembered it. So we will see what are the differences between this condition and TEN. So this is how the child is going to appear with all the sheet like epidermal peeling over the body, and you are able to see the redness of the skin. And because there is acantholysis as the underlying cause, true Nikolsky sign can be seen in these children. And yeah, very important, because desmoglein 1 is almost absent in the mucosa. So mucosa will be absolutely normal. Are you able to see this beautiful child who is having all these skin lesions, but the conjunctiva, and also if you see in the oral cavity, the mucosa will be absolutely normal. And here you are able to see the close-up picture where the eyes are absolutely normal, that is mucosa will be spared. And also you are able to see the Nikolsky sign here. This is the peeling off of the superficial layers of the epidermis from the underlying skin. So this is the slide which will help you to differentiate between toxic epidermal necrolysis. Remember students, toxic epidermal necrolysis is secondary to the drug intake and usually seen in adults, whereas this condition, this syndrome is seen in children. But in both of them we can see the sheet like epidermal peeling and the constitutional symptoms. But how can you differentiate further? Mucosal involvement is very classical in the form of hemorrhagic crusts in TEN, whereas mucosa will be spared or normal in SSSS. Treatment: admit the child, give parental antibiotics. So because we have discussed Ritter's disease, you should also know points about Ritter syndrome. This will be discussed in detail in the general medicine by Dilip sir, but let me give you some points from dermatological standpoint. Okay, this is also called as reactive arthritis. In fact, Ritter syndrome term is now being abolished. Okay, and we are going to use the term reactive arthritis. So we are going to see important features in this, which you can remember with the help of this mnemonic A-cubic. So the first three are actually the triad of the this particular reactive arthritis, conjunctivitis, and urethritis. And we can also see this circular balanitis, which is called as sarcinate balanitis. And the etiological agents are going to be infections like Shigella, Salmonella, and also Chlamydia. And in the keratoderma, you can remember there is going to be thickening of the plantar skin. So it is called as keratoderma. Specifically, it is called as keratoderma blenoragicum. These are all the points which you need to remember related to reactive arthritis. Next is acute paronychia. So remember, onychia is nails surrounding the nails, the skin. If it is getting infected, we call it as acute paronychia, and we can see the causative agent to be Staphylococcus aureus, and you are able to see there will be erythema of the nail folds, which you are able to see here, and there will be pus collection or purulent discharge which will be present here. And the important complication is there could be a possible lymphangitis which can present as this erythematous streak present over the extremities. And what is the medication which we can use? We can make use of the amoxiclav for the treatment of this individuals. Right. So if there is no abscess, just topical antibacterials will be sufficient. But if there is abscess, incision and drainage has to be performed. Next are the cutaneous corynebacterial infections. What are the corynebacterial infections? Erythrasma, trichomycosis axillaris, and pitted keratolysis. So erythrasma, I hope you might be remembering from the wood slump in the basics topic. So this is produced by Corynebacterium minutissima. So it will present as asymptomatic, hyperpigmented or erythematous macules and patches present in the axilla and also in the groin. So as such, this will not be having any symptoms in the patients, but because this is very obvious and it is very bad to look cosmetically, so the patients are going to come to the dermatologist for the treatment. And this is going to have even the involvement of the toe web spaces. This is something very interesting. So in this picture, actually, you can see that a person of erythrasma having the coral red fluorescence on wood slump examination. And you are also able to see these are the toe web spaces where again on wood slump you are able to see coral red fluorescence. And this fluorescence is because of the coproporphyrin 3. Next is trichomycosis axillaris. By looking at this term, you may feel, mycosis means this should be a fungal infection. But remember, this is a misnomer. So now in the recent books, the name is being changed to Trichobacteriosis axillaris. Hopefully it might be changed one day completely in all the books. And the causative agent is Corynebacterium tenuis, T for trichomycosis, T for Corynebacterium tenuis. And here what we can see in the axillary hair, obviously it is going to affect the axilla. Axillary hair, we are going to see yellow concretions which are attached to the hair shaft. Okay, and even this sweat may become yellow in color because of these concretions, and this may cause staining of the clothes. Next condition is pitted keratolysis. So whenever you see the name of the disease, remember the name of the disease will help you to understand the features clinically. So there will be lysis of the keratin, because of which there will be formation of the pits. So that is the reason why it is called as pitted keratolysis. And what is the organism name? So it is Micrococcus or Chytococcus sedentarius. And this is going to produce the depressions in the stratum corneum due to the serine protease. So this organism is going to eat away the stratum corneum, because of which you are going to see multiple pits in the palms and in the soles. And this condition is also associated with increased sweating. Next condition is scrub typhus. This is very important from PSM point of view. Also, you should also be in a position to identify the organism which is associated with this. So patients are going to have the fever and also CNS manifestations. Etiological agent is Orientia susugumishi, and the vector, very important, this is the trombiculid mite, and the infective form is going to be the chigger, which is the larval form of this mite. You need to even know this image also. You should be in a position to identify it in the examination. And clinically, yes, fever and CNS symptoms will be there. And the lesion clinically in the skin, what we can see is there is going to be a black colored eschar, which is going to be surrounded by the erythema, So in the center, what you are able to see is a black scab. Okay, this is called as a scab plus peripheral redness. We call both these together as eschar. And remember, eschar is a term which you need to remember. There are three important conditions in which we can see eschar. Okay, so this is the small mite. So remember, the scrub typhus drug of choice initially used to be only doxycycline, but now you can remember the NEJM has mentioned that a combination of the doxycycline and azithromycin could be a better drug of choice for scrub typhus. So the differential diagnosis of the eschar, like I have told you, remember there are three important conditions. One is cutaneous anthrax produced by Bacillus anthracis and the scrub typhus, and also the brown recluse spider bite. This is poisonous spider which can produce this eschar formation in the skin. Remember one negative point, KFD. KFD stands for Casanor forest disease is not going to present with an eschar. So by looking at KFD, you might be remembering KFC, but no, it is Casanor forest disease. It will not have an eschar. This is a negative point which you need to remember. So this is the cutaneous anthrax, which is causative agent is anthracis. It can manifest in the skin, also in the GIT, and also in the pulmonary system, respiratory system. And lesions are going to be very important malignant pustule, which is a double misnomer. It is neither malignant nor it is a pustule. So what is the lesion which you are going to see? It is going to be a eschar which is going to be surrounded by the rim of the vesicles. By a rim of vesicles which you are able to see, this is called as a malignant pustule, which can be seen in cutaneous anthrax. This is another picture where you are able to see malignant pustule. So coming to Pseudomonas infections, remember three of them: ecthyma gangrenosum, hot tub folliculitis, and green nail syndrome. So ecthyma gangrenosum, remember one point, it is associated with immunocompromised individuals in whom Pseudomonas is going to spread through the blood. That is, septicemia will occur. It will produce hemorrhagic necrosis of the skin, and there will be necrotic crusted ulcers present over the skin. Remember, there are three ecthymas which you need to know: ecthyma gangrenosum, Pseudomonas. Ecthyma pyogenicum is due to Staphylococcus, that which we have discussed after impetigo. It is ecthyma which is going to be deeper skin infection in the dermis. And next one is ecthyma contagiosum. This is odd man out, which is due to the parapox virus or virus which will occur in the persons who are handling the goat and the sheep. Ecthyma contagiosum. So one trick with the help of which you can remember this is a viral infection is, I hope you all know, molluscum contagiosum is a viral infection. So with the help of that, remember ecthyma contagiosum is a viral infection. Coming to the hot tub folliculitis, so those individuals who bathe in the ill-maintained spa, they are going to get the folliculitis over the bathing suit area, that is a trunk area, which is described as the hot tub folliculitis. Next is green nail syndrome. Due to the spiocyanin which is produced by the Pseudomonas, the nails are going to appear green in color. This is what is called as green nail syndrome. This is what is called as green nail syndrome. Next is meningococcemia, the causative agent, you know, it is Neisseria meningitis. Signs of meningitis will be there, fever will be there. What is the cutaneous feature? On diascopy, we can see the petechiae purpura and ecchymosis. And this is precisely called as angular cutaneous infarct. This was also previously asked. You must know about this term. Angular cutaneous infarcts are classically seen in the patients of meningococcemia. Few points about the streptococcus which you need to know from dermatological point of view. So toxin mediated manifestations are scarlet fever. Skin lesions due to allergic hypersensitivity which you need to remember are erythema nodosum and vasculitis. This is a proactive factor for very important gutted psoriasis and also the Kawasaki disease. And remember, streptococcus is not associated with carbuncle. Carbuncle is due to staphylococcal infection. Next, we are going to discuss the cutaneous tuberculosis, its classification, and the important diseases clinical features. So, based upon the mode of acquisition, we have exogenous, endogenous, and if the tubercular bacilli, they are producing the skin lesions due to the hypersensitivity reaction. That is called as tuberculosis. So, in the exogenous, remember we have TB chancre, tuberculosis verrucosa cutis, and lupus vulgaris. In the endogenous, remember very important conditions: scrofulloderma, orifacial tuberculosis, and also the lupus vulgaris. In the tuberculosis, remember important condition: Buzzins disease. So first condition is TBVC, which is called as tuberculosis verrucosa cutis. So if you observe the name verrucosa is written here. See, wherever you hear this term verrucosa, I hope you know this, the skin is going to be very, very rough in those diseases. So in this condition, remember, either anatomists or pathologists previously used to get in contact with the dead bodies. They have to handle the dead bodies. So the MTB bacilli used to be inoculated into their palms or soles, because of which the verrucous lesions used to be produced, which will be seen usually over the extremities, most likely in the distal and distal or acral extremities. And you can remember, the dead body handling is now being taken care of with utmost safety measures, because they can be any kind of infection which can be transmitted. Okay, one such example is TBVC, and this is the example of post primary form of cutaneous tuberculosis. This is how the lesion of TBVC looks like. You are able to see that the skin is very, very rough, uneven surface. Over the feet, you are able to see this. Okay, and feet, you can see extremities, and this is also called as warty tuberculosis. Remember, warts are associated with human papilloma viral infection, but this is called as warty tuberculosis because the skin lesions appear rough surfaced. And one more disease which will have the warts is obviously common warts. So how can you differentiate between the common warts and the TBVC? For your practical purposes, for exam point of view, remember, in common warts there will be multiple sites which will have the rough surface, whereas in the TBVC you are going to have a single lesion. What are the other differences? So in the TBVC, we can see in the lesion there can be discharge. If you try to palpate the skin, it will be very, very thick, that is induration, and there can be also scarring, which are absent in the common warts. You can remember those with the help of this number. Okay, what is DIS? Number stands for discharge, induration, and scarring. So whenever you are in your preparation mode, whenever any other person is calling you, the response which should come is, this number cannot be reachable. This number cannot be reachable. This number is discharge, induration, and the scarring. Remember this. You should be very busy in reading so that you are going to become successful later on. Very, very important to remember in your preparation. These are some of the other images where you are able to see the rough surface, uneven surface, verrucous surface over the skin. Buttocks. If a child is sitting on the floor which is having the sputum of MTB bacilli, their buttocks also can have this tuberculosis verrucosa cutis lesions. Next condition is lupus vulgaris, which is the most common presentation of the mycobacterium in the skin in adults specifically. And how is this spread? Remember, both exogenous as well as endogenous routes can be causing this condition, but the endogenous cause is very important when compared to exogenous through the blood. And remember, the patients are going to have a very good immunity. Cell-mediated immunity is very good. This is the reason why only few bacilli are going to be seen in this lupus vulgaris patients. And how does it present clinically?